All right, everybody, as usual, looks like we have a couple of stragglers, but we can't afford to be waiting too long to get started because we have a lot of content today. So in the future, try to get on a little bit earlier if you can, just so that we can get started on time and get out of here on time. If you're just joining us, please get in the chat box, sign in with your state number and full name. Okay, while we're waiting for a couple more people to show up, we're only going to give them just a couple more minutes. I just want to thank everybody for coming tonight. Once again, I'd like to acknowledge, the fact that we are in such dire straits with EMS and everything right now. Our family, just like everybody's family around the couple of states that we're doing this class in, I'm sure you've all had your losses and your illnesses. So we just need to take care of ourselves a little better. We have to be diligent on that PPE and diligent on our vaccinations and everything else, so that we can keep taking care of the people we need to take care of and take care of ourselves. Make sure you're following your local protocols, your local COVID protocols to the letter. They're there for your safety. Like Larry said, tonight we have Cleveland Clinic's critical care transport team talking about ventricular assistance devices, as well as Nationwide Children's Hospital going to talk to us about pediatric cardiac arrest. So I'm going to turn it over to Larry and let him do the introductions. And the standard rules apply. If you have a question, feel free to put it in the chat box. If it's appropriate, you can unmute yourself and ask the question. We do ask that everybody monitor their mute button and make sure that you're muted. We get a lot of feedback when you're not. I'll see you in a few minutes. Here's Larry.
Well, welcome to tonight's lecture. We're very excited to have Abigail and Justin from the Cleveland Clinic Critical Transport Team. And they're on board here along with Laura Holdren and Dr. Beth Bubolz. They're from Nationwide Children's Hospital, and they're going to be talking about pediatric cardiac arrest. And so I just kind of want to reiterate, this is a cooperative production between Trumbull Regional Medical Center and Youngstown State University. And through our networking, we're able to bring you guest speakers from all across the state of Ohio, Pennsylvania, and also West Virginia. We're also going to have some other national speakers, such as author Dan Limmer, who writes EMS textbooks, and some EMS law firms joining us later on in February. So I'd like to turn it over right now to Abigail and Justin from the Cleveland Clinic Critical Care Transport Team. And whenever they're ready to share their screen, the show is yours. Thank you very much, and I look forward to your lecture.
Thanks for having us.
Give us 1 second to get set up here. Sorry about that. This one?
Yeah.
All right. Can everybody see that okay?
Yep, we got it.
All right. Let's get started. Thanks for having us. So I'm Justin Lonczak. I'm one of the nurse practitioners here at Critical Care Transport for Cleveland Clinic. And then joining me tonight is Abby Brown. She's also a critical care nurse practitioner and happens to be my boss as well. So let's get started. We'll talk a little bit about do's and don'ts of LVAD management. So a couple disclosures we always throw in here. No one's providing us any compensation for endorsing these products. The clinic has used all these products in some way, shape, or form throughout the process and timeline of LVAD management. The clinic doesn't support any of these or endorse any of these products. Again, they've all used them. This is not a competency or certification course, strictly informational for you guys. And obviously, if any information we put out here tonight conflicts with any existing protocols or procedures you guys have, I would defer to your medical director before you use Justin told you so in a court of law, because it's not going to stand up. With that, this presentation was designed mainly with the regional protocol that Cuyahoga County in Ohio uses So some of the things that we may talk about, while they're usually universal in nature, may be specific to the squads and EMS providers in this area. So the objectives of things we're going to talk about tonight, we're going to talk a little bit about the significance and classification of heart failure. We're going to talk about why we would put an LVAD in, what are the indications for that. We're going to talk about the basics of LVAD parameters, or the numbers that you're going to see on the device when you start looking at them. Talk about the basics of the HeartMate 2, the HeartWare, and the HeartMate 3. We're going to focus more so on the HeartMate 2 and the HeartMate 3. The HeartWare product, as you'll see, is still out there in circulation, but it's not being produced anymore. It's not really being implanted that much anymore as well, mainly because they took it off the market. The basics of LVAD alarms and management we're going to go over, and then we're talking about assessment and treatment of these LVAD patients, and then what kind of hospital resources are out there as well. So at the end of the day, why do I care about heart failure? Well, about 6 million Americans roughly live with some degree of heart failure in the US, and a little over 500,000 people annually are diagnosed with some degree of heart failure. That's the single most common cause of hospitalization in our patients over 65. And I'm sure if you've been working in EMS for any length of time, you've seen quite a few of these patients on a weekly basis. It's a very extreme financial burden on our healthcare system. It costs about $30 to $40 billion per year just for this single disease process alone to manage. And each year, about 2,000 to 3,000 LVADs are placed across the United States. The Cleveland Clinic currently averages about 70 to 100, but for the last few years, it's been closer to that 100 mark, if not more. In this area as well, University Hospitals puts in LVADs. And then other areas, I think now that we're talking about a statewide thing, I know OSU in Columbus would, Christ Hospital in Cincinnati would, sure UPMC puts them in. Those are just a couple of the ones in this area that are coming to mind. So again, getting back to heart failure. Well, last year, about a little over 7,000 people were listed for a heart transplant. When we're talking about heart failure, we're talking about advanced heart failure. And the gold standard of management of advanced heart failure is that heart transplant. Problem is, a little over 2,000 people actually got one last year. A little over 600 people died while waiting, which leaves us about 4,500 people last year alone who were listed for heart transplants who are still waiting for it, and they still have heart failure, and they're not getting any better, right? So we have to do something for them. That's where LVAD comes in. So let's briefly go over heart failure. What causes it? Well, heart failure falls into two categories. There's ischemic cardiomyopathy and non-ischemic cardiomyopathy. Ischemic cardiomyopathy may be things you're a little more familiar with. That's your long-standing hypertensive patient. That ventricle is beating against a lot of resistance over time. It keeps trying to accommodate for that as it can, but eventually it can't, and it will fail. Other common causes for that are coronary artery disease or an MI. MI affects that area, a large area of heart muscle. Again, the heart tries to grow to expand that, but eventually it can't, so it will fail as well. Non-ischemic causes are things like valvular problems. So you may have aortic insufficiency or mitral insufficiency, things like that. Viral or bacterial cardiomyopathy can happen. In the era of COVID, we've been seeing a lot of viral myocarditis, which affects the heart muscle. The COVID virus will affect the heart muscle and can cause the heart muscle to fail. We see a handful of peri and postpartum patients every year where the stress of labor or just the stress of being pregnant on the body can actually cause the heart to fail. So you'll get patients in that realm as well. Drugs, toxins, and alcohol play a role in just about every disease condition under the sun. And then there's idiopathic cardiomyopathy, which is kind of the fancy medical way of saying we're not really sure why your heart's failing right now, but it is, and we're going to do something about it. So again, if you guys have been in EMS for any length of time, you've probably seen this patient. This is your patient with left-sided heart failure. We're talking about LVADs tonight, left ventricular assist device. So we're talking about supporting the left side heart failure patient. So this is that person that's probably sleeping in bed on multiple pillows. They don't lay flat anymore because they can't breathe. Maybe they don't even sleep in bed. When you find them, they're in the recliner in the living room because that's where they sleep now. They probably have a couple miles of oxygen tubing strung throughout the house, get jammed up on under all the doors, hung up on things. They're usually always congested. They have that chronic cough. They're usually a little bit wet when you listen to them, even on a baseline standpoint. Walking around the house, they're tachycardic. They get short of breath very easily. They fatigue very easily, things like that. We've all seen this patient. So on the inside, this is what they're looking at. There's my mouse. Hopefully you can see the mouse as well. On the left side here, this picture is a normal heart. So it's, again, it sits right in the center of your chest, a little bit off the left side of that sternum there. It should be about the size of your fist at the end of the day for a normal patient. The X-ray on the right here is a patient with heart failure. You can see their heart is significantly enlarged. Most of this is left ventricular muscle mass. This patient has had some long-standing problem, or again, has had a heart attack, something like that. Their heart has grown to try to accommodate, to keep that cardiac output pumping at what it should be at, to meet the body's metabolic needs. But eventually it can't do it anymore, so it'll fail. So these are a couple of echo images. So these are our cardiac ultrasounds of a patient with heart failure. Again, these are not playing great, but they're playing okay. This should be a little more streamlined, but you can see the actual contraction of this heart muscle here is not going very well. Likewise, this picture over here, this is the left ventricle. These walls should almost be completely touching each other, give it within a little bit as they contract and inject blood out of the heart. Again, this is the left ventricle over here as well. Aorta comes up through here. This is your left atrium, your mitral valve separating the two. The aortic valve you can't see in this picture, but it'll be right here. And up on top is the right ventricle. The center picture is the one I like to focus on the most, though, because you can see here they injected some dye into this left ventricle. So as the dye comes in, essentially it's just swirling around in this failing left ventricle because the heart is not beating in sync and as hard as it should be beating there. That blood should be coming in and be ejected right back out this aorta right here through the aortic valve and out into the body. This blood is sitting stagnant. This is why that patient is chronically congested. This is why that patient, if we give too much fluid to them, they'll back up and they have congestive heart failure exacerbations and things like that because their lungs can't take this backflow of fluid from a heart that is not pumping forward. So at the clinic, we use this classification system for heart failure. There are others out there. We use the New York Heart Association classification. It's just a severity scale from 1 to 4, and it goes from increasing severity as you get worse. 1 is you had some sort of cardiac issue. Maybe you had an MI. You took a little bit of a hit to your EF. But really, you have no symptoms. You have no limitations. But as your disease progresses and things get worse, you fall further on down the classification here. To the point where you're on class 4 and you have severe limitations in physical activity. Maybe you can't even sit around at home without feeling like you're constantly having symptoms. Obviously, as we've gone down the spectrum down here, we've put these patients on more medications. So maybe they've already been on the beta blockers, they've already been on the ACE inhibitors, they've already been on their Entresto and all the other good medications that we use for heart failure and things like that. Somewhere in here, we've probably put an AICD in them. We may have talked about a cardiac resynchronization device or something like that if they've been an AFib or something along those lines. But basically, we've done all the different tricks we can, but their heart's still in failure. They're getting worse. And down here is when they're going to start being thought of as a person that we need to transplant. And in the meantime, we're probably going to start talking about LVAD because we have to support that patient to get to the transplant. So that's where it brings up the LVAD. What is it? It's a mechanical circulatory support device that's used to partially or completely replace that function of the failing left ventricle. There's 2 big reasons why we put one in. That's either bridge to transplant or destination therapy. There is technically a third option we can put it in, but generally speaking, in most centers that put in LVADs, we wouldn't put one in for that reason. We have better options, things like ECMO and Impella and stuff like that. But when we're talking about LVADs, we put them in for generally 2 reasons. There's bridge to transplant. So this is the person that's been approved for some sort of cardiac transplant. They're currently listed for a transplant somewhere, and they've obviously failed maximal medical therapy to get to this point here. So nothing's working for them. We have to do something for them to get to the point where we can get them that new heart. We would put an LVAD in for that. It would hopefully bridge them to that point, and then the LVAD would be explanted once they get their new heart. The other option is destination therapy. This is the one that's a little bit more tricky. This is the patient who's not a transplant candidate. And that could be for a whole host of different reasons why they wouldn't be considered for transplant. But also with this, they failed all their optimal medical therapy. And then when we look at their long-term outlook, if they don't get a device, they're looking at a life expectancy somewhere in the ballpark of less than 2 years. 2001 was when first LVADs were listed for this option. So you can see, while that is 20 years ago now, it's becoming more and more prevalent because more and more centers are learning how to put these devices in for this specific reason. They may not be able to transplant somebody, but they can put it in an LVAD now to support them and kind of live out their days on this device. And that's what destination therapy is. They're not a transplant candidate. We're doing something to kind of get them back to a point where they can do things in their life that they may not have been able to do before. They can go out and play golf, they can spend time with family, they can go walk in the park, things that they wouldn't have been able to do without this kind of a device to support their body. So what are the 4 parameters you're going to look at? Well, you have flow, speed, power, and pulsatile index. So I'm a part-time firefighter as well in Broadview Heights here, Ohio. So I put my fire truck on here because I think that this is a good way of thinking about an LVAD in these terms. So your flow, that's your liters per minute output. That's your cardiac output of the patient. That's the flow coming out of the nozzle at the end of your hand line going out onto the fire. Speed is the revolutions per minute that the impeller or the disc inside the device, we'll show you those things here in a minute, is running. And what it's measuring is how fast that's running to get that given flow. It's a fixed speed. We can't change it outside of the hospital. You have to be at an LVAD center that can hook you up to specific equipment to be able to manipulate the settings inside of this device. So when they leave the hospital, they're set with what they're going to be at. But if they were in the hospital and you wanted more flow at the end of your nozzle, you do the same thing you would on a fire pump, right? You'd increase the pressure on it, aka you would increase the speed of the impeller inside your pump to get that given flow. So speed correlates to flow. You also have power, which is measured in watts, and it's measuring the amount of power required by the pump to get that given speed to give that given flow. We measure that in combination with everything else here to try to determine what's going on if this device is alarming. The final thing we would measure is kind of an abstract idea here. It's called pulsatile index. This device, remember, is flowing, but the patient's heart is still contracting around the actual device. And I'll show you what I mean by that here in a minute. But it's contracting around that. So the device is smart enough to realize how much it's flowing out and how much the patient's native contraction is actually contributing to the LVAD filling at the end of the day. So again, when we look at all these measurements in the hospital, what we can do is we can kind of determine, is this patient maybe clotting? Is that the issue that's causing an alarm here? Maybe they're dehydrated, things like that. We can kind of take all these things together in form of essentially vital signs for this patient and kind of decide how we're going to go about managing this patient at the end of the day. So let's start talking about some of the devices. Well, on the left here, we have the HeartMate 2. On the right is the HeartWare product. HeartMate 2 is a little bit larger. You can see it's about the size of this palm of your hand, give or take. This portion of it here is cored into the patient's left ventricle. So they'll actually take a patient part of that left ventricle out. They'll implant this part of the device into it. Blood is then taken out of this part of the device. It's spun through the impeller, which you can see here is kind of a torpedo-looking device right in the center of the device. Is spun, pressurized, and then is put back into circulation via this graft, which is hooked up to the patient's aorta. So again, blood in, spun, up into the patient's aorta, out into circulation. This is the HeartMate 2. It's an impeller device. You can get about 10 liters per minute of flow out of it. And the thing I mentioned with all of these devices, and it'll come up later when we talk about management, is they're all even laminar flow devices. There's no pulsatility in any of these devices. So you get one flow, just like a fire pump. When you open the bail on the end of your nozzle to flow water on the fire, there's no spurting of water coming out of that. It's one even flow coming out of that end of that nozzle. So think about it that way. Again, the HeartWare device, you can see it's significantly smaller. So they improved on this quite a bit when they created this device. It fits right in the center of the palm of your hands. Blood will come in here. Again, they core this into the patient's left ventricle. They actually sew this white ring onto the muscle itself. Blood comes in, is spun around this copper disc right here, pressurized and ejected out that port via that hole, which usually has the same kind of graft on it here. They just didn't take a picture of it in this particular picture, which again is grafted onto the patient's aorta and is put out into circulation. You can see the differences between the two pumps here. The one's quite a bit bigger than the other. One of the downsides of getting a HeartMate 2, when it was the prevalent pump years ago, was that it actually had to be in place. While this part was created and placed into the heart, it was so big that it actually couldn't sit within inside the chest cavity. They actually would have to puncture through the diaphragm with both of these components, put them where they need to be. The device itself would actually sit inside the patient's abdomen, just about in the same area as their stomach, which would cause a lot of discomfort for the patient until they can get used to it, because there would be constant hummings feeling right next to their stomach. HeartWare, obviously, we can see is a lot smaller. The nice thing about this is it can fit completely inside the patient's chest cavity. It actually allows us to be able to use it on much smaller patients, because body habitus and overall body size was one of the constraints for what size LVAD we can put in you. So going off of what I was just saying, these are some x-rays of how that's implanted. Again, this device is cored into the left ventricle here. Blood is brought out, pressurized through the pump, and put back into circulation up to the patient's aorta here. Again, this is the HeartMate 2 device. You can see just as I was talking about, the diaphragm runs right about through here. That big black bubble right back there is the patient's stomach. So you can see the device is actually sitting in the abdomen, even though it's functioning for the heart. HeartWare device, much, much smaller. So fitting completely inside the chest cavity right here, in snug next to the heart. Blood comes in, is moved around, is put back into circulation over here. This patient as well has an AICD, which is something we talked about earlier, as our patients probably would have who have advanced heart failure. So this is the component, again, that's actually inside of the chest. So you can see here, this is what I mean when I say they core out a chunk of the patient's left ventricle. This was a patient who received a new heart. This is their explanted, a failing heart that had the LVAD in it. They actually will, again, core out a chunk of that left ventricle, and the device physically sits into it. This device is HeartMate 3, which we're going to talk about in a few slides. This is the newest device out on the market, and it's the one that, at least in the Cleveland area right now, is being predominantly implanted. But we'll get to that again in a few slides. I just like these pictures. I think it shows, again, what I talk about when I say they remove a chunk of your ventricle to put this in. So again, that was the inside part. This is the outside components here. So the exterior components, this is the controller. This is what hooks up, and we'll show you what it hooks to via a drive line to the actual inside part. It displays all your alarms, all your messages, all your parameters, anything you would want to know about the actual workings of the device inside the patient is displayed out here. So usually when we come out to you guys, we bring an LVAD with us. So I kind of hold it up. I'm not sure if you'll be able to see it depending on how close we get our camera or not. I don't know if we can zoom in on our camera or not.
I don't think they can see us.
Yeah, I'm not sure if they
No.
can see or not. But anyway, so this is the HeartMate 2 controller I have in my hands here. So you can see when you follow my mouse, that square button right there in the center, when you press that, it will illuminate the screen, and then it will cycle through all of the various pages of settings that are currently running on the actual pump that we have in front of us here. I'll zoom in on this on the screen in a second here to show you some other stuff. But what I want you to know about this controller down here is the HeartMate 2 and the HeartMate 3 controllers are the exact same controller. The buttons are the exact same, where the actual batteries and the drive line, everything that hooks into the controller are the exact same between the two. The only difference is the color scheme of the plastic that they chose to make the device out of. So this one is a lighter gray. The HeartMate 3 is a darker gray, and it says HeartMate 3 in the corner versus this one that says HeartMate 2. This is the HeartWare controller up here. It's a little bit different, but at the end of the day, all the stuff is really the same between the two devices, HeartWare and HeartMate 2. All the same buttons are in here. It's displaying the same characteristics. All the various settings and things like that are all the same on here. It's just how you manipulate the device might be a little bit different. Again, though, the HeartWare product has been taken off the market. The people who actually own HeartMate products bought HeartWare not long ago, and then they took it off the market when they took their technology. So things that you need to know about the controller, obviously, this is where you're going to see any of your messages, any of your alarms and things like that. This is where you're going to look to see and to try to interpret what's going on here. The other things you have to know is this has to have two power sources hooked up to it at all times. And the LVAD itself is very, very, very finicky about when it doesn't have power sources. So you can see I'll disconnect one of the batteries from our device here. And within a second, it's going to start beeping at me saying that I need a second power source right here. Hook it back in, screw the end back on, and the alarms will alleviate. So again, needs two power sources. So most of the time, these patients are on two batteries because they want the freedom of being able to walk around the house and things like that. They don't want to be tethered to the wall, but there is a home power unit, which we'll get to in a slide or two. A lot of times they'll go on that at night. They'll leave one battery on and they'll hook the other side of their adapter up to the home power unit, which just plugs into wall power. So that way they don't have to get up in the middle of the night to change batteries and things like that. So zooming in on it, again, this is the HeartMate 2 controller. A couple things that are important on here. This green light right here, this is the pump running symbol. I'm going to go back one slide here. This white light on the HeartWare picture here is the same exact symbol. What it's telling you is that there's power physically going into this pump right now. So there's power going from the batteries into the pump inside of the patient. That'll come up again a little bit later when we talk about assessing and managing these patients. Battery button here will tell you how much battery life is currently running on the actual battery that the device is drawing power off of. This button I talked about earlier is the square button. It will cycle through all the different screens. And if you have an alarm menu up there, it'll cycle through the alarm and how to manage that. And then the most important button on any piece of equipment is the alarm silence button. It allows you to silence the actual alarms on the device for a given amount of time, depending on the severity level of the alarm you're looking at. But it basically allows you to have a second to think in silence and try to assess things in silence without this thing yelling at you. Big thing that I'd like to point out, though, in this specific slide is there is nothing that you can push on this device while it's running that will cause the patient to self-destruct, that will cause the device to turn off. To actually turn this thing off, you have to do very specific set of buttons, and you have to have everything disconnected from it. So in other words, the patient has to be totally disconnected from the actual controller module to shut it up and to turn it off. So and that takes a little bit of stuff and thought process to actually be able to do. So again, if you have to assess this, you have to touch it and be able to manipulate the buttons to determine what's going on. Do that. You're not going to actually hurt the patient. So this is the drive line. This is the piece that actually connects.
You can see.
They can't see it.
No.
No, okay. That actually physically connects the LVAD inside of the patient all the way up to the controller unit, which we just talked about. So it connects the inside to the outside world. Usually it comes out the patient somewhere around their belly button. It could be on either side, just depends on how the surgeon decided to put it in that day. But it comes out and it connects the two pieces. Things to remember here is it should try to keep it as sterile as possible. These patients go through a very long series of education before they leave the hospital after these things are put in. They're taught that when they change this dressing, they usually do it once a day. It has to be a completely sterile environment. So they wear sterile gloves, they wear a hospital mask, they wear a sterile cap. Anybody in the room assisting them has to wear that same setup. They clean it very, very specifically, and they apply the dressing very, very specifically. And the reason for this is driveline infections are a very common reason this patient would actually come back to us in the hospital. Sepsis can happen in these patients, and the bugs that tend to infect our drivelines are kind of notoriously difficult to clear up. Usually these patients end up on long-term antibiotics over the course of a few months and things like that. So they're kind of a rough go if they get infection from this nature. And again, thinking about it from a septic standpoint, any bug that infects this is going to go right up the drive line. It could possibly reinfect their heart muscle, which could cause them to actually have worsening of their overall underlying condition. So we don't want that either. This device right here, this is essentially, it's basically designed for a Foley catheter, but we give it for our patients here. And basically what it does is allows a little bit of slack to be given in this line here. That way, if anything like the controller or the batteries were to slip or to fall, if the patient were to drop them, it wouldn't pull very hard on the actual physical site of insertion here, which could then damage the skin and open it up again to possible source of infection. So we just kind of, it's a redundant system basically to prevent things bad from happening. So the final component is the batteries. So again, the HeartMate 2, HeartMate 3 batteries are down here. They look exactly the same. They're small little cylindrical, square boxes, rectangular boxes that slide into this cuff right here, this holster, which then is clipped and is screwed into the part that goes into the patient's controller, powers the unit. This is the home power unit that I was talking about earlier. The patient can actually go onto wall power. And then this is the setup up here for the HeartWare device again. Again, looks a little bit different than one of the HeartMate 2 device or HeartMate 3 devices, but they're all doing the same functions at the end of the day. It's just the way it looks. So manufacturer says you can get 10 to 12 hours per a pair of batteries that you're running off of. That all depends, obviously, on the total amount of usage and the amount of draw. It's like your cell phone, right? The more you talk on it, the more you play games on it, the more you're on Facebook all day, the faster the battery is going to draw down. Same thing here. If I require a lot of flow or I'm requiring a lot of power to power my device, the battery's going to draw down faster. As well, it goes for age of the batteries, right? You get your cell phone is new. The longer you have it, the more charges you put into it, the faster the battery wears down. It just starts to get older. These patients usually leave the hospital with between 6 and 10 batteries. So they have plenty of batteries to run with and to actually use throughout the day. They actually have a charging unit that they go home with too. That usually most of these batteries will stay kind of put in a bank charger that they keep somewhere in their house as well. So that's important as well. HeartMate 2 will actually draw down both batteries simultaneously. Then require you to change them. HeartMate 3 kind of fix that problem, so it will draw down one and then it will automatically swap to the other battery as a redundant system. So they kind of fix that problem. The HeartWare, I believe, draws down both batteries at the same time as well. So we talked about HeartMate 3 enough. Let's go over it real quick. So this is HeartMate 3. So this is the newest product that they have out on the market right now. I know at the Cleveland Clinic, as well as university hospitals in downtown, this is essentially the only product they're putting in the operating rooms right now here for our LVAD management. Other hospitals, I can't speak to the areas in Columbus, Cincinnati, UPMC, what they're doing, but I imagine they're probably in the same ballpark, being that this is the latest and greatest thing. So it was just approved in 2018 for use via the Momentum 3 trial. And it carries an 83% survival rate at 2 years, which is the best survival rate at the 2-year mark. The 2-year benchmark is kind of what we use for almost all LVAD related things for long-term effect that we've seen out of any LVAD here. So 83%. Has a couple specific things to it that I like to go over. So it has what's called an artificial pulse wave to this. So I remember earlier I mentioned that there's always a linear flow, one even flow of blood coming out of the end of this device, just again, like your nozzle coming off your hose line off your truck. This artificial pulse wave is kind of a bad term. It's a little bit of a misnomer. All that is taking about 30 mLs of blood per minute and actually physically washing the housing, the internals of the actual device. So what that does is prevent any blood that was in there from sitting too stagnant, too long, and potentially clotting. So it reduces the risk of clotting in this device. It was not enough of a pulse wave to produce any sort of palpable pulse, which we'll talk about in management and stuff like that. So don't take that as I can feel the pulse of this patient, because you're not going to. Other things here is the device is fully magnetically levitated, which means the actual innards of the device, the disc that's inside of there that spins, is levitated between two magnets, which reduces the amount of stuff inside of there for blood to contact, which reduces the overall risk for clotting in the device. The gaps inside of that disc where the blood will actually exit from as it's spun around are larger, which reduce the risk for what we call blood trauma. Blood trauma is a term meaning that all the red blood cells, the platelets, all your clotting factors, as they come through the device, specifically in the older devices, they would actually physically get beat up, kind of like a piece of clothing that you threw in the washing machine, right? It gets beat up over time. These would get beat up, and eventually what these patients would actually acquire is acquired anemias, acquired clotting disorders, things like that. They may not have had one inherently, but because I'm beating your blood up for you, eventually over time, I can create one in you. So what this larger gaps does is it reduces that overall risk for that kind of complication for happening. The other fantastic thing that they've created here is a modular drive line. The old drive lines that we talked about in the older devices were one continuous piece of cabling that would connect from up here, just like this one is, coming off of the HeartMate 3, and would exit the body again and connect into the controller. They used to be one continuous piece. Which exposed it to risk of being damaged in the external environment. If you accidentally cut it, fray it, wiggle it around, and actually accidentally snap any of the cabling inside of it, the only way to fix that problem with the older devices was to go back to surgery and actually explant your LVAD and put you a brand new one in. We couldn't physically disconnect it at all. So the modular drive line actually exits, it's a little clipping piece that I can disconnect from the component outside your body, the drive line outside your body, and replace it with a new one as needed in case there was damage. So that saved a lot of people repeat trips to the operating room that didn't need to be there. So let's put it all together at the end of the day. What do we have? We have your patient's heart, again, with this is the HeartMate 3 that's implanted into the patient's left ventricle, again, cord in there. Blood comes out, goes and spun through the device, goes back up this graft, put into the patient's aorta, and then out into circulation. The drive line exits and connects up into the controller. This is the HeartMate 3, so this is that modular drive line piece I was talking about that we can disconnect. And then there's two batteries that come off of the controller and are hooked in here. This patient's wearing them in kind of, I call it the gunslinger configuration underneath their arms. It doesn't necessarily matter how they have all these components, but they have to have everything with them everywhere they go. They have to have two batteries, the controller, all of it has to go with them. So this is their life for the rest of their life here. The batteries and things like that, again, a lot of patients will carry them in different ways. I've seen people that just put them in their purse. I've seen people that have like a satchel bag that they wear. They sell clips that you can hook to a belt loop or something like that. I've seen people just shove all the stuff in their pockets. But again, no matter how they carry it, it has to all go with them no matter what. So your LVAD is alarming at this point in time. So let's talk a little bit about management, how we look at the alarms, interpret what they are, and how we're going to go about fixing the issues here. Again, your LVAD's alarming. First thing you do is you take a deep breath. This is your patient's problem. This is not your problem. You're just here to help them. So if you're freaking out, obviously, like anything else, you can't do that as efficiently. So take a deep breath yourself and assess your patient. Look, listen, and feel. We all learned that mantra when we took BLS, right? Look, listen, and feel. It's the same thing applies here. So we're going to look to see if the green light that I mentioned that was on the HeartMate 2 and HeartMate 3 products, or the white light that was on our HeartWare device is on. If it's on, we know that that pump is getting power from the batteries. Next thing we're going to look at is the controller itself. What's the warning message that's being displayed to me on the actual device? It's going to tell you what's wrong with it. It could be something as simple as when I disconnected the battery earlier on here, I disconnected the battery, it said connect battery number 1. That could be your fix right there. So it's going to tell you what it is and what it wants you to do to fix the simple problem, or the simplest thing you can do to fix the problem on the device. And then finally, trace your drive line, trace your power lines, and make sure everything is seated and connected appropriately. It happens every once in a while that the drive line won't seat as firmly as it needs to seat in the controller. Usually the device should alarm at you and tell you that that's an issue, but sometimes it does, or it comes undone somehow, something like that. Or same thing, maybe the power lines aren't seated into the actual battery clips themselves very well. So trace all the lines, make sure everything is nice and snug, everything's connected appropriately, because you might fix the problem just simply doing that. Next thing you gotta do is get your stethoscope out and start listening to your patient. Again, usually when we do this device or this class in person, you can hear the LVAD that we have with us humming. It's a little bit hard to do that probably via Teams here. But if you had a patient with an LVAD, you would get your stethoscope out, you're gonna listen to either their chest or their abdomen, doesn't really matter. Pretty much anywhere on the thorax, you'll hear a distinctive LVAD hum. It doesn't sound like any other physiologic process is going on inside your patient, so you really shouldn't confuse it with anything else. If you want something to think about it wise, I always reference it as it sounds like your dishwasher when you turn it on at the end of the night, right? It makes that humming sound as the water is whooshing around in there. If you're listening to that patient, it sounds like something like a fork flung loose in the dishwasher. Not a good thing. That should be such a couple of specific instances that can cause that. And if you don't hear any hum, even worse, right? So we need to fix that problem as well. So the last thing you're gonna do, look, listen, feel. Feel the controller unit itself. It probably will normally, or should I say, well, probably, it will always feel body temperature warm, right? So it's up against the patient's skin, it's in their pockets, it's gonna feel body temperature warm. But if it feels abnormally hot, something like you've been using your laptop all day and the battery's heated up really good because it's been drawing a lot of power all day long, that abnormally hot electrical kind of feel like that, something's wrong with it. It's drawing a lot of juice from the batteries to try and supply whatever the demand is inside the body. Last thing you're gonna do is talk to this person, your LVAD coordinator. At the end of this PowerPoint, I have phone numbers for the Cleveland Clinic and for UH. But at the end of the day, your LVAD coordinator's number is going to depend on obviously whatever center you're nearest. So if you're in the Cincinnati area, again, I would advise you to look out and see what Christ Hospital's numbers are. If you're in the Columbus area, OSU is going to have a specific number. Again, anywhere you're at in the country, it's going to be a specific LVAD coordinator designated to that LVAD center that implanted those. So, but you want to talk to them as soon as you can, because they're your best friends in dealing with these patients. All of these LVAD patients have to go back to their LVAD center for routine management and routine evaluation frequently, especially in the early stages after they've had this put in. They're here almost on a weekly basis. So these LVAD coordinators, they know these people. So if you tell them, hey, I'm Justin, I'm from Cleveland Clinic, and I've got this person. They're going to say, oh yeah, Joe Smith or John Smith. I know him. I saw him last week. He's got a heart rate 3. What can I do for you? They're going to be able to walk you through anything that's going on with this patient. They'll be able to describe the alarms to you, describe management to you, and they're going to be able to help you along the way and walk you through things on how to manage this patient. Remember, they are not your medical director. They're not your medical control. So if they do ask you to do something that seems a little oddball, I would reference your medical director first. But generally speaking, at least in the Cleveland area, I have not met a medical director that has gone against the wishes and said, don't do what the LVAD coordinators say. The LVAD coordinators know these patients. They know the devices much better than the EMS coordinators out there, the EMS directors rather out there. So generally speaking, they're going to lead you in the right direction here. So other big things to remember when you talk about an LVAD that's alarming is that 90% of the alarms you're going to see from these devices, it's not the actual device malfunctioning. It's the patient that's got the problem. The device is just responding and alarming to a condition that the patient is presenting it. So we'll talk more about that in a few slides here too. But so it's something that a lot of people kind of mistake, and they think when the LVAD's alarming that this device is going to blow up in front of me in a few seconds here, like it's on a self-destruct switch. It's not the case. Usually it's your patient that has the problem, and that you have to kind of do the detective work now to figure out what it is to fix the actual alarm. So here's the alarms. They come in 3 flavors, red, yellow, and green. Your red alarms are high priority alarms. They're continuous tones. They can't be silenced, or they can be silenced for only a very, very short period of time because they're the ones that are life-threatening. They're telling you something like the pump has stopped working, the flow is less than 2.5 liters per minute, which is not enough to support brain function and things like that, support life, or the pump itself came disconnected in some way, shape, or form. So basically, long and short, these alarms or something is incompatible with life here. So we got to fix them right away. Yellow and green alarms, generally speaking, are more along the lines of having a problem with battery power, or they're telling you that you're going to be running out of batteries in sometime in the near future. Usually these alarms can be silenced for a longer period of time because they're not as life-threatening as the pump stopping itself. The only other thing that a yellow alarm can throw at you is what we call a suction event in here. Again, the device is designed to run at the speed and the given flow that it's set at when they leave the hospital. So the device wants to run at that regardless of what's going on inside of the body. So especially this time of year when you have a patient who maybe has the flu and they're throwing up, they have some diarrhea, something like that, something that's causing them to be a little bit dehydrated. The body is not supplying the device with the amount of blood that it needs to actually flow. So what can actually happen is the device can start to suck that intraventricular septum. The septum divides the two ventricles. And actually start to suck it into the actual inflow cannula on the device, which obviously is a bad thing because it's going to eventually occlude the actual cannula and it can cause a big problem. The device, the LVAD, is smart enough to realize that this is what's happening, and it will intrinsically slow itself down to the point where that intraventricular septum will naturally free up off the device. But it's going to send you an alarm because if it happened once, it's probably going to happen again. You have to fix the patient to be able to fix the alarm again in this case. So this would be something where we would give some fluids, usually manage them that way, or blood if they're bleeding, something along those lines to manage low blood volume. But again, that's an event that would usually come in as a yellow alarm because it's not one of these things that's kill you in the next few minutes, but it could kill you soon, so it's going to throw a yellow alarm at you. In the pictures here, again, you can see this one up here in the top right. It's the HeartMate 2 controller again. You can see the green light is on, so we know that there's pump power going into the patient. The next thing we're going to do is look at the actual controller screen here to see what's going on. This is telling you that it's actually got a driveline fault. So remember that 10% of things I told you couldn't go wrong with the device? This is one of those instances. The driveline actually has a fault in it. So this is a hardware problem, unfortunately, with the device. And it's telling you what to do. Call the hospital because there's nothing you're going to do out in the field to fix that. So call your hospital contact, AKA the LVAD coordinator, to tell you what's going on here. The next thing you can do if you wanted to see anything further that I might be able to tell you to alleviate the problem, you could hit that squared button right there. It would flip you to the next screen. Generally, if you have an alarm on there, something like, let's say that alarm said low battery. You hit that square button, the next screen is going to tell you the easiest thing you can do to remedy the problem. It would say something along the lines of change the battery. So again, it could be that simple. Sometimes it takes a little bit more than that. The arrow picture in the hardware device down here will do the same thing. It'll cycle through the picture on the screen, or the image on the screen rather, and tell you what's wrong, and then again, how to actually fix that problem, the easiest thing you can do. So now that we've looked at the alarms and things like that, we have to assess the patient, obviously. So how do we get a blood pressure on this patient? That's tricky at best, again, because remember, this is a non-pulsatile laminar flow device here. There's no pulsatility here. There may actually be some. That's not exactly 100% true. Depends on the patient's underlying native heart function. Sometimes if they have a decent enough underlying heart function, you could feel a very, very faint pulse if you felt for one. But 90% of the time, this patient is not going to have a pulse when you go to feel them because it's one continuous flow. The LVAD's doing the majority of the work. And then honestly, physiologically, the longer that LVAD is in the patient, what actually happens is the aortic valve actually calcifies over to the point where no blood's going through it anymore. All the blood's exiting out of the LVAD, so you're really not going to get pulsatility anymore out of it after a while anyway. So how do we get a blood pressure then? We're out in the field, in the middle of anywhere, and we're trying to manage our patient. In the hospital, generally speaking, if the patient's an extremis, we're going to put an arterial line in this patient. That's usually what we do at CCT, not generally an option for us out in the EMS world. Next thing you could try to do is if you had a Doppler, I'm talking about a Doppler like you would use to listen to like fetal heart tones or something like that. You could take that in conjunction with a manual blood pressure cuff and inflate it and kind of take it. It's akin to doing like a palpitated blood pressure, right? So you find the Doppler whoosh sound of that blood going through the vessel. You inflate your cuff to the point where you can't hear it anymore, and then you release your cuff. And when you hear the sounds come back, you watch for where the needle's at. That will tell you what your mean arterial pressure is here. Again, there is no systolic and diastolic here. We're talking about what the mean arterial pressure is. And what that is the number, that's the actual pressure that your organs are seeing at the end of the day after that systolic wave comes through there anyway. So it should be between 65 and 85. We'll talk about that again here when we talk about managing low blood pressure and stuff, I think, on the next slide. If you don't have those, most places say I've only encountered a handful of squads out there that actually have a Doppler, that I like the type that I'm talking about here. You could try your non-invasive cuff. We all know that certain brands of non-invasive machines work better than others. If you're going to get a non-invasive cuff to actually pick up on a patient, I would tell you to do it in an environment where you're completely sitting still. Patient's couch, their bed, things like that are probably the best places you can do this. Sometimes even a little bit of engine idle from your truck sitting stagnant while you're trying to assess your patient right up front is enough to kind of throw that off a little bit, because it's looking for a very fine number. And almost all of our machines out there these days are interpreting what the mean arterial pressure is anyway, and they're going to spit back at you a systolic and diastolic number that it back calculates essentially from the mean arterial pressure. So let's say you used your non-invasive cuff and you were able to get a blood pressure. What you're going to look for again is the mean arterial pressure on there. That's the number that's in the parentheses that we usually don't write down on our vital signs. We want to look at that. Again, it should be 65 to 85. And if you're getting a non-invasive pressure, then when it comes up, don't be surprised. The numbers are very, very close together here. Again, laminar even flow. You're not going to get a big systolic and diastolic number here. You're going to get very close together numbers, 70 over 60, 80 over 30, whatever it may be. You're going to get numbers that are close together. If none of that's working for you, what we do is we go back to EMT basic school. We assess skin color, temperature, mental status. We kind of use things as surrogate markers for perfusion, right? Anybody who's got pale skin, they're diaphoretic, things like that, those are all not good things. We know anyway, right? So if your skin color is pale, you're diaphoretic, maybe your mental status is a little bit off, your patient's a little bit sleepy, maybe they're unresponsive at all, we can kind of use those things as surrogate measures of what the blood pressure is in the first place. We know they're not perfusing enough if they're not talking to us to perfuse their brains. So their blood pressure is probably not that good going upstairs at that point. Other thing we can use is capnography. Most squads out there these days have the nasal cannula capnography. Put that on your patient. A normal end tidal reading generally can be interpreted as the patient having adequate perfusion and circulation. Your end tidal reading has to come from the CO2, which is produced by your cells. Your blood has to be, if your blood is able to be pumped out adequately enough and perfused out to the tissues to bring that CO2 back to the lungs to be interpreted by your monitor, you can interpret that as what the patient's perfusion and circulation is like. Same reason we can use it for ACLS, right? To monitor for pulses and to monitor for adequacy of CPR. Caveat to this, obviously, is you have to make sure that this LVAD patient didn't call you for a COPD exacerbation or their asthma attack or something like that, which could skew these numbers, right? So we have to make sure that the data we're interpreting is the appropriate data. Most places at the end of the day know that it's very difficult to get a blood pressure. So if you do show up at the ED without a blood pressure, they may look at you kind of strange at first, but then once you tell them and explain to them the situation, hopefully they won't hold it against you. So let's say we got a blood pressure and now we have to manage a perfusion problem. Or maybe we thought the patient just had signs of bad perfusion because they weren't talking to us or they were pale, cool, clammy, diaphoretic, all those good things, right? The LVAD itself is what we call very preload and very afterload sensitive. It's a kind of a princess device in that way. It wants what it wants in the conditions that it wants it. And if you go outside of those parameters, it's going to alarm at you and tell you have a problem and I don't like the situation in front of me. It's an assist device. It can't pump out what the body can't give it. So if your blood pressure or your preload is low, aka you're dehydrated maybe, or maybe you've been bleeding somewhere, GI bleed patients sometimes have this problem. Your body can't move from the right side to the left side what the LVAD needs to be able to flow out. The LVAD is going to alarm at you saying we have a problem here. Likewise, if your patient decides to stop taking their hypertensive medications for some reason, or they ate the wrong meal maybe, and their blood pressure goes up, stuff like that, and the pump senses it has to pump out against a lot of resistance, it's not going to like that either. And it's going to alarm at you saying you have a problem in that regard as well. So it's going to be, again, a very princess device. It wants things inside a certain range, and that's it. The other thing that can cause preload problems is right ventricular failure. Maybe your patient's having a heart attack, and it's a right ventricular MI. Maybe that's an inferior MI that moved to the right side of the heart as well. I need to keep the right side of my heart intact when I have an LVAD, because the right side is moving blood over to the LVAD to be pumped out. So if I take a hit to the right side of my heart, the LVAD is going to notice that. So at the end of the day, let's say again, you're hypotensive, maybe you got a number that was hypotensive, maybe you're seeing a patient that just has bad signs of perfusion. We're going to do something about it, right? First thing we're going to do this patient is give fluid. LVADs love volume at the end of the day. It sounds counterintuitive to be giving patients with advanced heart failure fluid boluses, but at the end of the day, we have to give the LVAD what it needs to be able to supply the body with the perfusion that it's asking for as well. So we're going to give it fluids. Start with like 500, see what that does with you. Crystalloids are great here. If you know your patient's bleeding and you can give blood products, that's good too. But if you're just giving crystal, that's fine as well. Start with a small bolus, 500, see what the patient does with it. If they're not doing well and you still have some time before you get to the hospital, you can give them another bolus, things like that. At the end of the day, I don't think I would dump a whole lot of fluid in this patient either, because again, even if they have an LVAD, they still can't handle an excess amount of fluid. But small amounts of fluid usually are enough to perk these patients up pretty good, to the point where maybe the alarm will alleviate and the patient might look a little bit better. Big thing we don't want to do in these patients, unless the LVAD coordinator or your medical director is advising you to do it, don't start pressors in this patient, because at the end of the day, I don't care what vasopressor you're using, almost all of them will constrict peripherally and just increase preload, or sorry, increase afterload rather at the end of the day. So all you're doing is increasing the afterload, and you're causing essentially a problem that the pump maybe didn't have before, right? Because now it has to pump out against increased resistance, and it's not going to like that either. So vasopressors usually are not the answer in this patient. Occasionally they are, but I would let the LVAD coordinator or your medical director make that decision for you at the end of the day. If they code, that's kind of an interesting problem. Excuse me, because chest compressions are a maybe at the end of the day. What the overall fear is, we're fearful that if you do chest compressions on this patient, you could physically dislodge the pump that's, again, surgically implanted into the left ventricle. If you dislodge the pump from the left ventricle, obviously that's the end game for the patient and it's all over. But the thing is, in 2017, I believe it was, they did a study, I believe it was 11 patients that were immediately post-op LVAD implantation. They all coded in the ICU. That all of them got CPR. All of them had return of spontaneous circulation. None of them had pump dislodgement, and I think it was 80% of them had intact neurologic outcomes after the arrest. I was hoping that AHA was going to comment on this and maybe put something out, yes or no, do compressions, like stand firm ground on most recent iteration of ACLS. They didn't. So we're kind of stuck here again in this gray area. So generally speaking, and again, this is what our protocols in the Cleveland area go off of. If you listen to that patient's chest and you hear an LVAD hum that's present there, we don't do CPR on this patient. The reason being is that LVAD is likely flowing blood around equivalent to the amount of what our CPR is going to be able to do for us anyway. So we don't do CPR on the patient in that regard. If the LVAD is not functioning, if you don't hear the LVAD hum, and when you look at the device, you don't see the green light on the HeartMate devices or that white light on the HeartWare devices that tells you the pump is getting power, we got to do something for that patient at that point because nothing's moving blood in the patient. Then CPR is indicated. So again, not functioning, give CPR. LVAD has got a pump present and there's power going into it. Don't do CPR. That's what we're recommending in the Cleveland area at least. As well, in the Cleveland area in our protocols, we're telling our EMS providers that if you are going to do CPR on this patient, do not use your Lucas device or your AutoPulse or whatever you've got. We all know that those devices do better CPR than any of us are even able to manually do. So if there is a chance that we're going to dislodge the actual pump from the patient, it's more than likely going to happen on that device's watch, right? It's going to do better CPR and it's going to dislodge the pump possibly if it's going to happen. So unfortunately, we have to go back to manual CPR, if you want to call it that, on these patients if you're going to code them. All right, so that being said, everything else under the ACLS protocols and procedures is fair game. You can defibrillate these patients till the cows come home. You can cardiovert them. You can give them all the epi you want, all the amnio you want. You can intubate them. You can do all that good stuff. You don't have to stop the pump to defibrillate or to cardiovert this patient. It is completely grounded. You won't short the pump out. You won't fry into the wires. You won't break the batteries, nothing like that. So leave the pump running and defibrillate as needed around it. Again, if the pump has power and there's an LVAD hum present, we just don't do CPR. You do everything else though. What's that? Oh, we only 5 minutes left. Oh, wow, we're running behind. So there's this possibility too, though. There's an oddball possibility, rather, that the patient could actually have what we would consider a lethal rhythm and be completely walking and talking and doing everything else that you and I are doing right now. And again, that's because the LVAD is essentially being able to flow enough outflow to maintain perfusion to that patient. This was a patient that we had in one of our ground units who obviously it appears was in torsades, but you can see their blood pressure was perfusing, their end tidal is perfusing, their SpO2 is perfusing, everything looks good. This would be a patient that I would write home about and see what they want you to do with them before you actually manage that actual rhythm. Clotting, bleeding does happen in these patients. It's one of our underlying things we're very concerned about. 17% of these patients who have an LVAD who survive up to that 2-year mark are going to have some sort of ischemic event. Or it could be a hemorrhagic event, depending on the type of stroke they're having. So in other words, if they're not talking to you and the device is not alarming, I would start thinking stroke in these patients here. And the reason being is all these patients are on Coumadin. Generally speaking, at least in the Cleveland area, we don't put our patients on Xarelto, Eliquis, Pradaxa, all those newer age anticoagulants and things like that. Reason being is Coumadin I can easily reverse with some FFP and some vitamin K. Versus having to have a specific reversal agent for some of those other anticoagulants. We kind of use it as a lowest common denominator thing. If our patient is in the middle of nowhere and we know they're on Coumadin, almost all ERs have vitamin K and some FFP available. Not all small community ERs have the specific agents needed to reverse Eliquis and Pradaxa and all that good stuff. GI bleeding, another common reason why these patients come back into the to the hospital for us. Obviously, again, it's a laminar flow device, so any sort of little aneurysmal area that would have been growing in the gut or in the brain, when it's under constant pressure and not under systolic relax kind of pressure like a normal person, they can actually start rupturing and bleeding from those sites. Usually they're very slow bleeds over time, especially our GI bleed patients. So eventually what they'll do is they'll call 911 because they just don't feel good, they're fatigued, things like that. Once they get in the ER, they'll realize their blood counts are way off and they'll figure out they've been bleeding. Trauma is unique to the pre-hospital environment for these patients. We treat them like any other trauma patient. The big thing you want to make sure is that they're not plugged into their vehicle. They do actually make adapters that you can plug into your vehicle so you can charge the device and run the device off your car's power. Watch what you're cutting, and that includes the driveline. So when you take this patient out of the vehicle and you're starting to assess the patient, you're cutting their clothes off, you're doing your trauma exam, just remember that there's a drive line running underneath that clothing. If we cut the drive line, I can't fix that without going back to the operating room, or if it's HeartMate 3, finding a center that can have a new HeartMate 3 drive line that I can switch out with it. All these patients should have extra LVAD equipment with them. This is a very big issue that we're going to talk a little bit about in a minute here. Bring it with you if you can to the hospital. Should be within arm's reach of them. Usually it's in a little black bag. It looks like an old style camera camcorder bag. But bring it with you because they're going to need the batteries that they have. Immobilization's up to you guys. Just remember they are anticoagulated. Talk to that LVAD coordinator because if they're going to help you kind of make the decision too, if you need to go to a trauma center versus an LVAD center, depending on where you're at in the state, some trauma centers are not LVAD centers. So just because you're taking your trauma patient to a trauma center doesn't mean that they can handle the LVAD. Case in point, in the Cleveland area here, Metro Medical Center is one of our level 1 trauma centers in the area. They are not an LVAD center. So if you call them and tell them you have an LVAD that was in a car accident, they're going to tell you to go to actually to university hospitals, which is down the road, because they can handle the LVAD and the trauma at the exact same time. So kind of have to know what your trauma center's capabilities are as well. These patients all still have heart failure at the end of the day, so we have to manage the underlying symptoms. Again, usually the alarms you're going to get are related to something that's going on in the body. If the patient has jumped into a funky heart rhythm, that can affect the flow to the pump, and that's going to be what's spitting an alarm out at you. So maybe they jumped into SVT, which some of these patients will jump into. You might have to cardiovert them out of that to get the alarm to actually alleviate. They can still have MIs. We can do 12 leads on these patients without worrying about anything. You'll still see a cardiac rhythm. Likely it'll be a paced cardiac rhythm, so you're going to have to interpret your 12 lead based on that. Christmas just passed. These people can still eat a full salt load, a whole bunch of ham at Easter or Christmas and get that pulmonary edema and all that good stuff. They can get pneumonias, all those things. At the end of the day, whatever their underlying symptoms are, you have to kind of determine, is it affecting the pump? And based on that, do I have to fix the underlying problem? Or can we kind of just take them into the ER for evaluation? Other important thoughts I touched on a second ago, to bring all their equipment with them to the ER. This is a common problem that we've actually run into a lot here at Critical Care Transport. Patients come to the ERs and they don't have extra equipment. They're told that they're supposed to have that black bag with them everywhere they go, even if they're going to the corner to grab a gallon of milk, if they're going to the gas station to pump gas, whatever it may be. They have to have, they're supposed to have, I should say, an extra set of batteries and an extra controller with them at all times. They get complacent over time and they leave these things at home, and inevitably that's when they end up in the ER. Problem is, at least in the Cleveland area, the only ER in the Cleveland area that I know of that has actual LVAD equipment stocked in the ER is Cleveland Clinic Main Campus ER. Even all the rest of our satellite regional ERs don't have LVAD equipment in them. So if you bring this patient to the hospital and they don't have extra batteries, they don't have extra equipment, they're running off of whatever they had when you brought them in, which creates a big problem. To a point where we've actually had to put, and we do currently right now, have LVAD batteries on all of our helicopters and all of our ground trucks, because we've had to bring them out to outlying centers to get patients power that they need. We've had to call police departments so they can break into houses, things like that. So it gets interesting if they don't have this equipment. So if you can bring it, bring it. This is an example of a tag that's usually hanging off of these bags. It tells you where the patient had their LVAD put in at. This is the LVAD coordinator's number you can call. If you have a cell phone, you can bring up this QR code. It'll actually bring you to a page, and it'll tell you how to manage some of the device stuff. It'll tell you how to change batteries, change controllers, all that kind of stuff. And then on the left side of the tag, it kind of tells you some generalities about the pump and how to manage. Families and family members are considered device experts. Somebody living with this patient, could be a wife, son, uncle, daughter, doesn't matter who it is, but somebody before they left the hospital had to learn just as much about this device as the patient themselves. So if that person's around, treat them as a device expert. They can help you manipulate the device and interpret what's going on as well. If you can bring them to the hospital with you, if they want to go, that's great. But bring them along as well if you can, because they can help you a lot. Again, remember, these patients are still human. They can call 911 for non-LVAD related issues. So if they get sick, they could just have the flu and they're calling 911, but a lot of places will flag these people in their CAD systems as having an LVAD. And then once you see that pop up, that's all your brain thinks about is, this is an LVAD problem, this is an LVAD problem, this is an LVAD problem. And you miss a lot of other things because you're not looking at the bigger picture. So again, this is a copy of our protocol here at the Cleveland Clinic. This is based on the Cuyahoga County protocol, universal protocol. These are the numbers for the LVAD coordinator at the clinic, and then the bottom one is the LVAD coordinator at university hospitals, the 2 LVAD centers in the Cleveland area. Obviously, depending on where you're at in the state or Pennsylvania, West Virginia, figure out where your local LVAD centers are. Their numbers are going to be obviously available to you guys as well. I would advise you to put them in your squad phones or wherever you would tape them to the wall of the squad, something like that. In the event that you get these patients, you're going to need to talk to them as soon as you can. So to summarize all that, I think I beat it to death, but talk to your LVAD coordinator as soon as you can. They're your best friends here. You can't break this device. Anything, the buttons on it, you can push them, manipulate whatever you want. You're not going to break the device, short of ripping out all the cables, which takes a little bit of work too. You can't break it. Look, listen, and feel to your patient, see what's going on. LVADs love volume, so at the end of the day, start there if you think you have a hypoperfusion problem. No CPR unless somebody tells you otherwise, or there's nothing going on with the pump itself, and bring everything you can with them to the ER because they're going to need it in the ER. And that's all I have for you here. If you have any questions, obviously, like Larry said, you can put them in the chat here. I have to sit here and go through the chat. I didn't get a chance to see it while I was presenting. Unfortunately, my screen's full screen right now. I couldn't see it. If not, if you have any other particular questions, feel free to email myself or Abby. We can help you with anything you need. We can get you resources. We can get you copies of things, stuff like that. We're very open when it comes to LVAD education, regardless of what health system you work for and things like that. We just want these patients to obviously have better outcomes as far as EMS management. So let us know what you need, and we can definitely help you from there.
Hey, Justin, there's a Sorry, Justin. There's a question from Lauren Edmonds. We'll let her go, and then I believe Jenna Rendez, and then I'll try to facilitate some of this real quick with the last couple minutes.
Okay, I have a couple questions.
Yeah, fire away.
The first question is there any electrical interference or artifact from the device on an EKG?
You might get some vibration from the device depending on where it's at in relation to like where you put the actual EKG leads and stuff like that. So like if you, for instance, if you had like a heart rate 2, remember I said that was the one that kind of sat more in the abdominal cavity. As you put like V3, V4, V5 kind of around the area it needs to be in, you may get like some vibration in there that may kind of just show up on EKG that way. You should still see the QRS. It may skew your ability to truly nitpick into there. It's possible, I guess, but really you should still see a picture. I wouldn't think there wouldn't be enough. I wouldn't think that would totally negate the ability.
Okay, and then so we'll still be able to do like obviously 4 lead and 12 leads. And then
Correct.
when you were talking about a code, again, this might be a silly question. If we're evaluating a patient that we think is in cardiac arrest, obviously they're unresponsive, probably in respiratory arrest. We cannot check for a pulse because they don't normally have one. And then obviously what the monitor would say, or like end tidal. Is there anything else that would be like a sudden code thing that I'm not putting together in my brain?
I don't think so. I think you kind of hit it all there. I mean, like I said, obviously you're not going to be able to necessarily assess pulses and stuff. You'll see the rhythms on the monitor. You'll kind of go by that, determining if your patient's flatline or if they're defib, whatever it means. But yeah, I mean, as far as like doing, unfortunately, when you stop for a pulse check, like ACLS will tell you to do, you're not going to be able to necessarily feel the pulse on there. You just have to look at your rhythm and decide, is that a perfusing rhythm or a non-perfusing rhythm, basically.
And you would also listen.
You can listen to, but again, if you heard it once, it likely probably hasn't stopped unless for some reason the batteries totally ran out of power or something like that. But yeah, it wouldn't hurt to continue to listen, make sure you're hearing all that hum in there.
I don't know how many people can see through or can see what we're here. It's kind of hard, and I guess I wish that we could be in person just to show you. We have a loop with us, which is a heart mate 2 that was explanted from a patient. And it has just kind of a big loop that we carry around. We hook into the controller. You can kind of, you can't hear it because we're in the conference room, but we wish we could kind of show you. But the one thing that I think someone just texted just to say is disconnecting the battery. I'm going to disconnect it real quick so you can at least hear it. I don't know if you heard it earlier.
Walk toward the camera, maybe
I don't know if you can hear it now. It's just hard to. It's hard to do all this. Sorry.
We get close
We
to the
haven't done
camera.
this virtually yet. Sorry. Do you hear that? So that's kind of an annoying noise. Sorry. But that's what the battery sound will sound like when you're disconnecting one of the batteries. I'm connecting a battery back up here. It goes into the clip like Justin was talking about up here. And then this is the controller. I'm just sorry. Okay. Coffee. This just generally speaks as to where it is located. Patients generally have their 2 batteries that connect here, and then this is the drive line with the controller here. So if you can see all this, it's kind of what it looks like size-wise. But if anyone that's not too far away from us wants us to come do an in-person training at some point once COVID settles down a little bit, we'd be happy to come bring this out and show your teams and schedule some training. So I think the hands-on portion is really important for people. It really helps to see all of this.
Kind of brings everything together when you can play with it.
Jenna Rendez, did you have a question? She raised her hand.
No, I'm sorry. That was a premature hand raising. I
Okay.
apologize.
All right. Anthony asks, what's the difference between CPR and Lucas device? Why would you not want to use a Lucas device?
So Lucas device is like the big reason we wouldn't use it is because we know from all the studies that it's doing better actual CPR than any human out there can do, right? So and if you have one, if you've used one, you've probably noticed an increase in the ROSC rates, the return of spontaneous circulation rates you're probably getting. So that's the big reason we're not doing it. And because it's doing so effective CPR, we're worried that it's going to actually physically blow out essentially the actual implanted site at where the left ventricle and the LVAD meet right there. We can actually disconnect it by doing that. So the risks are there for when you do, if you did manual CPR, like if you or I were doing it. But generally speaking, they're going to be less so than if we use the Lucas device or any of the other mechanical CPR devices out there.
Okay. Al in the Liberty Township Fire Department wants to know, do we still do 20 minutes of ACLS and stop, or do we transport, or is there a termination protocol? And are you familiar with any LVAD hospitals down in the Youngstown area that could assist?
No, I think you would be either going to UPMC or be coming to the clinic or University Hospitals in Cleveland. I don't think Justin and I are familiar with anyone
No.
in the Youngstown area. We
have
actually have gone out for emergencies out that way. We've had to fly to aircraft because people didn't carry their batteries with them. So.
And as far as the 20 minutes of ACLS and stop, I would probably, that'd be one thing I would reference maybe if you have regular communication with your medical directors and stuff like that. That's a good question. We actually, at the fire department I'm with, we have a protocol the same way that we can terminate CPR, after 20 minutes of ACLS, depending on the overall situations and stuff like that. That may be a gray area though for your medical director, because I'm not saying that the LVAD is going to necessarily keep them alive. If they're gray and as hard as this table, they're obviously gone. And that's happened before where we've gone places and the outside hospital physician has wanted to continue CPR in the decoding the patient when it's kind of obvious the patient is gone. So I would probably follow up with your medical director in regards to what they want you to do in that situation. Because you're kind of in a tricky gray area that doesn't really follow the normal ACLS kind of stuff.
I just tried to answer one of the other questions about just follow standard ACLS with electricity and medications. No deviation there. But again, all of this, please refer to your medical control and please refer to your protocols that are in place.
And if you guys don't have an LVAD protocol, you guys can actually go on to the Cleveland Clinic's EMS website. If you just Google CCF EMS, it's one of the first pages in there. All of our protocols should be online. If you don't go to this Cleveland Clinic site, you can go to University Hospitals EMS protocol. Same thing, Google University Hospitals EMS. And their protocol is the exact same as the Cleveland Clinic's because they share a regional protocol with us. But you can actually see what our true LVAD protocol is on there. So if you didn't have a protocol in your guys' protocol standing for LVADs, it'd probably be a good thing to add in there. They're not an everyday occurrence, depending on where you live. Obviously, some communities are going to have these more often than others. There's a community, Avon, in the Cleveland area here that we were at not too long ago that has something like 20 of these patients living in it. But they also do have a rehabilitation center for the clinic that rehabs some of these patients as well. So I guess there's a one-off there. These patients, they travel a lot, especially around the holidays here. They can go anywhere, obviously. They have the freedom to move. So, we get calls sometimes that, patients coming from Michigan to see their family here in Ohio. They're going to be staying at XYZ address. Usually they contact the fire departments in those areas, that sending hospital that patient belongs to. Generally will contact the fire department in that area that the patient's going to be staying in, letting them know that they have patients in their community and that they should go to this facility if something was to happen. But not always do they do that, unfortunately. So it's possible that anybody anywhere anymore can have an LVAD patient. It's not isolated in specific areas anymore.
Awesome. Well, Justin and Abby, thank you very much for your time. I appreciate you. And we'll definitely try to host you guys down here for a seminar once COVID restrictions lift and we can see the LVAD devices that you have.
Sounds good.
Sounds great. Thank
you. Thank you very much. And then we appreciate you. And anybody else still left in the chat, we'll go ahead and take a 5-minute break here. So go ahead and please raise your hand, or if you're unable to do that, please chat in the box your name with your state number. Take 5 minutes. It's 7:13. We'll come back at 7:18 and we'll have Laura Holdren and Dr. Beth Bubolz from Nationwide Children's Hospital. Thank you.
Having some issues with your screen. I cannot hear you at all. You might have to take yourself off mute. Still can't hear you, but at least you're separate from your, at least you're not superimposed over your lecture.
Absolutely. Hang on. I want to do it. I'm just going to do plain presentation. Oh my gosh. I unplugged my headphones.
I can still hear you.
You can or you cannot?
Yes, I can
Oh,
hear you.
so you can hear me. I unplugged my headphones and it took me forever to get it back. I think I'm just going to share my screen without my face.
I mean, that's fine.
What do you, let's see.
I think it's fine once you switch to talking, that you can just switch it over to presentation. I don't think they need to, maybe they can just see you when they all come back.
This one or this one? Reporter mode. Can you see my screen right now?
No.
Let's try this. Oh, that's the same one. It's just kind of weird.
Yeah, I think you have to flip it back over to the other mode where you weren't.
Let me see. Here. Hang on.
There you go. Well, now you just flipped it back. You had it where you needed it.
Dang it. But I couldn't see it.
Oh, yeah, that's where it can get a little bit difficult.
So I need to share. Let me
See,
unshare.
yeah, that's the part where I can see your screen, but I can't see.
But you can't see the slides. So then I'm going to share content. I'm just going to do it like this and this and this. And
there, now I can see your screen again.
you see my now.
Yeah, I can see your slides.
Now I just need to put it as a slide. How's that?
There we go.
You can't see
there you
me.
go. Awesome. Very good.
Well, I
Very
kind
good.
of had this and I thought, well, it's going to be this disembodied slides with no face, but that's fine.
Well, but I can see your face in the sidebar.
You can see my face? Okay.
I can see your face in the sidebar. I just didn't want to turn on my camera too to like displace you, since I'm gonna push you up to the front, since
you've got the spotlight on you, Doc.
Oh boy.
It does. So I am
gosh.
super lucky, since I am the full-time EMS educator, but I do not know everything. But I am so lucky that I have a whole list of people when I am not a content expert. And Dr. Bubolz is so kind as to not only be our medical direction over our education program, the EMS liaison for Nationwide Children's, but also she is boarded in pediatric emergency medicine and cardiac electrophysiology.
For kids only. So I really loved the talk before. That was a very awesome talk. Are we ready to go ahead?
Yeah, Doc, whenever you're ready, everybody in the chat, you can, or on the call, you can put your hand down. And I'm apologizing now. I'm sorry I messed up your name, but I gave it the best shot I had. But
that's probably the correct German pronunciation. When my renegade grandparents moved from Wisconsin to Texas, we became the Bubolz clan.
Okay,
so
very good. Without further ado, here's Dr. Beth Bubolz and Laura Holdren from Nationwide Children's Hospital. Thanks.
Okay, so I'm going to talk about resuscitation and sudden cardiac death in pediatrics. And the first, I don't know, let's see, I'm going to keep track of the time because I have a lot of material. The first part is just kind of interesting, and then we get to the meat and potatoes of what can cause this and what it is. But I want to go with a little history of resuscitation, going back as early as we can for resuscitation, and then talk about sudden cardiac death in pediatrics, covering the causes and the statistics and why it's important, and then a little bit about resuscitation today, touching on neonatal resuscitation. So we've all heard, oh, wow, they really had me over a barrel. And there's some debate over what this means. It may just be you were in a very bad spot, but early ideas about resuscitation would drape the body over the barrel and they would roll back and forth in order to try and get some sort of resuscitation or return of circulation. Other things that they did is they would put hot coals on the chest and try to restore the breathing. But the knowledge of circulation and pulses came a lot later. That is, unless we look in the Eastern literature. Back in the Han Dynasty in China, 200 years before Christ to 220 after, um, Zhang wrote about the golden chamber, and this is probably the earliest record that I could find of CPR. They would resuscitate victims of hanging, and it seems like there was probably a lot of hanging going on at that time in China. But the recommendations at that time were to stop after 30 minutes. So here's the actual document, or a copy of it, I imagine. And the document is called The Golden Chamber. And they would talk about resuscitation of the hanging victim. And they would slowly embrace the victim, untie the rope. And in all their literature, it's important that you untie it, don't cut it. They recognize that death is associated with the body being cold. So they would cover the body. One person would put their feet on the shoulders and raise the head by pulling the hair, and the second person would press on the chest or the belly. And then the third person would massage the arms and the legs, and they would do this for 30 minutes. And if it wasn't successful, they would stop. So after that, we get to the Jin Dynasty. In 266 to 420 AD. And Hangi wrote the Handbook of Prescriptions for Emergencies. And this is the first recorded use of a reed for artificial airway. So they would place a reed through the mouth and down into the throat, and then a second person would pinch the nostrils and blow, and then they would hear borborygmus or bowel sounds, and that told them that was an unobstructed airway. The feet were raised and they used herbal medicine to induce sneezing, and they would stop when the patient was able to speak. And so then they also described medications to use post resuscitation. Later in the Sui dynasty, up to 618 AD, they wrote about a general treatise on the cause and symptoms of disease, and they recommended that CPR be started as soon as possible, or this resuscitation method. And they actually gave ventilation and circulation equal importance. Pretty amazingly, they were so forward thinking in these early days, and unfortunately, CPR in China has fallen way behind the rest of the world today. But later in the Tang Dynasty, they would talk about plugging the ears, moxibustion, which is igniting little plugs of herbs in certain chakras on the body. Acupuncture was used, and then they substituted a bamboo tube for the reed, and they would continue, instead of stopping after 30 minutes, they would continue for half a day. So this is the evolution of resuscitation in the East. So in the North Song Dynasty, we're getting up to 1100 AD, is the first account of the family giving mouth-to-mouth resuscitation. And then later, still was more popularization of CPR. And then a published report of a family saving a hanging victim by, and this implies that bystander CPR was used probably for the first time to save a life. Then going on into the 1600s until early 1900s, more publications were published on resuscitation. They refined the approach. They included some traditional medicine, and then also, once again, seems like there's always the question of when to stop. So defining limits. In modern China, the focus is on CPR training, and standardized training is really in a great need. And towards the end of the talk, we talk about what China has done recently. But sadly, with all of this rich knowledge in the East, there's only a 1% chance of survival for out of hospital arrest in China today. If you look further in Persia in the 1440s, Nafis el-Kermani just had a huge manuscript where he recognized deep breathing with strong movements and massive chest expansion were required to correct a respiratory arrest. And then they, in this treatise, recognized pulselessness, and so trying to stimulate a pulse. So in the Western medicine, really goes back to probably in Italy. The newborn kiss of life was where a mother would blow into the mouth and nose of a newborn to attempt to resuscitate a stillborn baby, or neonatal resuscitation. Vesalius in the 1500s initiated mechanical ventilation using a bellows to the trachea. And then in Edinburgh, Taussig talked about mouth-to-mouth ventilation. So there was a coal miner who was revived of being overcome by poisonous gases, and they talked about mouth-to-mouth ventilation being very simple, safe, and at least it can do no harm. So this is one of the earliest Western recorded use of mouth-to-mouth resuscitation or ventilation. Then around 1776 in England, they took this information from Edinburgh, and in England, the Society for the Recovery of Drowned Persons developed a list of techniques for reviving drowned people, and they focused on ventilation. And actually, the interest was greatest in Holland, where they have a lot of canals and fjords and a lot of drowning deaths. So the society in Amsterdam in 1776 published their recommendations. They would warm the victim. They would remove any swallowed water and place the head lower than the feet, not demonstrated here in this photo. They would apply manual pressure to the abdomen for the expiratory phase, and then release air into the victim's mouth with a bellows or mouth to mouth. So these first 4 items that they had are sort of the precursors that survive in modern resuscitation. But they had a few extras that probably fall in the category of plugging the ears and moxifloxacin. So they would tickle the throat, they would fumigate the nostrils or the anus with tobacco smoke, and then they practiced bloodletting. So these have thankfully fallen by the wayside. So in the Western medicine, the bellows for ventilation was universally adopted around 1784, and they actually set out little resuscitation kits along the Thames River. James Curry in 1792 published popular observations from apparent death from drowning and suffocation. And they talked about here in animal studies recoverable versus absolute death. So there was a recognition as early as 1792 that there are some deaths that you can recover the patient from, but then either based on the timeline or the mechanism of death, he categorized this as absolute death. They then in the 1800s, they abandoned artificial respiration, which is really kind of a step backwards. The concern here was that the exhaled air in mouth-to-mouth resuscitation had oxygen removed from the resuscitator, and the resuscitatee was getting oxygen poor air. And so they just were like, we can't be doing this. There was concern for lung rupture with the bellows, and there was a scathing report that said the bellows should be relegated to its natural position next to the fireplace. And then instead of respirations, they began to focus on external chest compressions. In 1846, the first recorded use of ether and chloroform anesthesia was recorded at the Mass General Hospital. And so you'll see a shift in the mid 1800s for resuscitation from drowning victims towards resuscitation of patients in the operating department. And this is actually a statue in the public gardens in the shadow of Mass General Hospital in Boston, which is dedicated to the first use of anesthesia. So you can see that there were some parallel developments where they started using external cardiac massage, but in 1896, Moritz Schiff recorded internal massage when he was studying death with chloroform. And then around the turn of the century, the first success of with internal cardiac massage on humans was recorded because most of these deaths were on surgical patients. So at this point, not only did they abandon the artificial respirations and mouth-to-mouth respirations, they abandoned the idea of external compressions. And so external compressions didn't come back until around 1933. So William Cohenhaven was an engineer. He wasn't a medical person, but he was very interested in resuscitation, defibrillation, and you can see his crew here: James Jude, who was a physician, Dr. Cohenhaven with his pipe at all times, and then one of his graduate students who I think worked with him for decades. And they're leaning on a defibrillator, which was, you can see the air quotes, portable. So the story goes that James Jude and Knickerbocker were doing some experiments on dogs in the lab. And the dog went into ventricular fibrillation, and they didn't want to lose the dog, and they didn't want to abandon the experiment. So one of the guys did CPR or tried to keep the dog alive, while the other guy ran to the other floor and brought this 200-pound machine up. And what they found is they noticed that when they would apply these super heavy paddles, that the blood pressure would go up. And so that spurred them to investigate external compressions. And it was basically a derivative of the heavy paddles on the chest, which caused the blood pressure to rise. Then modern resuscitation and CPR in the West can be attributed to Dr. James Elam, Peter Safar, and Archer Gordon, who were a cardiologist and anesthesiologist, and I think a general practitioner. But they did experiments to prove that exhaled air had sufficient oxygen for resuscitation. And then Safar confirmed the original findings. And in 1960, they talked about combining mouth-to-mouth resuscitation and external compressions, and now we call it CPR. And Dr. Gordon was instrumental in teaching the community and getting the idea out. So it was a long way to get to the resuscitation that we have today. Interestingly, in 1988, which is a year before I graduated medical school, PALS was initiated. And so there's not really much written on the history of PALS. I can tell you as an intern in 1989, when I trained in PALS, we had anesthetized cats that we practiced intubation on. And one of my colleagues took one of the cats home and called it PALS. But that's kind of the history of PALS that as I know it. So we don't have that many years if you think it's in our career time or our lifetime that we've really started focusing on PALS. But sudden cardiac death in pediatrics is sort of where we're going with this. If we talk about sudden cardiac death, I'd like to talk about terminology and numbers. Like, it's a low incidence but high importance disease, why it's important. We'll talk about diseases that cause sudden cardiac death, and I have this set up as a few case studies that we can talk about, and then a little bit about modifiable barriers and about neonatal resuscitation. So sudden cardiac death has been defined as non-traumatic death occurring within 24 hours of acute onset of symptoms. It is also called sudden unexpected death. And it's contrasted a little bit with sudden cardiac arrest, which is malfunction or cessation of the electrical or the mechanical activity of the heart, resulting in almost instantaneous loss of consciousness and collapse. So the difference is that sudden cardiac death talks about outcome, and sudden cardiac arrest focuses on the symptoms. So when we talk about the problem of sudden cardiac arrest in kids, Michael Ackerman published this where they looked at all causes of kids. Now, the dark purple line represents the very youngest children, 1 to 4 years of age, and the lighter purple line represents kids 5 to 14 years of age. So if you look at all causes, and this is in, like, it's 26.5 1 to 4 year olds per 100,000 population. So you can see all causes not that high when you compare to adults. Unintentional injury, accidents, congenital anomalies, of course, higher rate of death in the younger age. Homicide, cancer is about equal in both age groups. But then heart disease is really only 1 per 100,000 kids, or 0.5 per 100,000 kids. And it ranks 5th or 6th in leading causes of death. These numbers are from 2016. I don't know if we'd have different numbers from influenza and that at this point. So a study in the Danish population shows the number of cases of sudden death and the age of the children on this axis. And so you can see that there's sort of a bimodal distribution where sudden death occurs in the very youngest and then has another spike around the older teenage years. And so this is just sort of like, what age groups more frequently die suddenly. Now, if you look at mortality rates per 100,000 in children and adolescents for the top 10 leading causes of death in the US, and you go from 1999 to 2016, you can see a drastic decrease in motor vehicle crash deaths. And I can tell you this is due to seat belts and car seats. And then firearm related injuries, fairly stable, malignant neoplasm, congenital anomalies, all of these are fairly stable. And then heart disease has shown just like a gradual, very slow decrease. So there hasn't been a huge difference over the years. So if we look at sudden cardiac death, so death in kids due to cardiac problems, it averages about 2 per 100,000 person years. 1,500 deaths in the US per year. Survival in the 1980s was about 13%, and survival in the 2000s is 40%. And so largely these efforts are due to increased survival because of EMS. This is a somewhat busy slide, but if you look at the U.S. registry, United Kingdom, the NCAA, and the U.S. military, these pie graphs show the distribution of what causes sudden cardiac death in, say, the United States. And if you look at the U.S., it is predominantly this blue thing, which is 35% hypertrophic cardiomyopathy. Some of this is artificial because it depends on how hard you look for things, because sudden unexplained death in the UK and possible hypertrophic cardiomyopathy or LVH are about, they take up most of this pie. And so it depends on sort of like, do you do a molecular autopsy? Do you have any type of information prior to death? And then sudden unexplained death in the NCAA is 31%. Coronary artery anomalies comes in at 14%. Dilated cardiomyopathies, myocarditis is an acquired heart disease, usually viral cause. And then in the military also exposing coronary artery anomalies that had prior been either minimally symptomatic, some of it's undefined, and lower hypertrophic cardiomyopathy because you probably get weeded out because of a murmur or physical findings. So looking at younger kids, congenital in the 0 to 2 age range. Primary arrhythmias, which some could argue are congenital, also a bigger piece of the pie than other things. In the ages of 3 to 13, you'll start seeing kind of an even distribution between congenital, hypertrophic cardiomyopathy, long QT, some other type of arrhythmia, and then sort of undefined. In ages 14 to 24, you still have some of these kids dying of congenital heart problems or other problems, primarily arrhythmia, myocarditis, long QT. And then hypertrophic cardiomyopathy takes a smaller bite out of it, but dilated cardiomyopathy is about 14%. Then once you hit 25 and certainly past the age of 35, coronary artery disease becomes the most common reason that you drop dead. In kids who have heart disease that's been repaired, there's one older study that shows aortic stenosis as a higher incidence of sudden cardiac death and detransposition of the great arteries. And if you think about this just in general terms, any sort of left-sided lesion is going to carry a higher risk. So whether it involves the aortic valve, the mitral valve, DTGA probably has a high incidence of sudden death because you have the aorta and the pulmonary artery have to be switched. And so surgically they have to reimplant the coronaries. So puts them at risk for coronary incidents. So let's consider, if these numbers are really so small, why is it important? And I came up with really 3 reasons. One is that a lot of these kids will die because of like during sports, not because sports are inherently bad, but because they are they have a higher surge of adrenaline. They may feel bad and not want to come out of the game if it's a big game, if they're the highest performer, highest scorer. There are also implications for families, not only the significant loss of a child and the unnatural history of death of a child, but also implications for genetically inherited conditions. And so the concern for the surviving children or adults in the family who may have carried the same gene but not have expressed it. And then I think it's very emotional for the community. It's if it's during a sporting event, it can be very public. Communities amongst schools are small, and it can be just devastating for a community. So let's look at the physiology and the hemodynamics. So why does anyone have sudden cardiac death? Well, I mean, you know, keep it simple answer is because they don't have cardiac output. Cardiac output is determined by a person's heart rate and the stroke volume, or the volume that's pumped with each heartbeat. I kind of like to break it down into three areas. It could be pump failure, so the muscle itself is failing the heart, the ventricles. It can be electric failure, so this encompasses all the arrhythmias, or it can be obstruction, such as a narrowed mitral valve or narrowed aortic valve, any type of obstruction. And ultimately, if a child is born with severe pulmonary um, stenosis, then no blood can get into the lungs, no blood can get out of the lungs, so that can lead to shock also. All right, as far as pump failure, these are all the things: ischemic, heart failure, sepsis. It's interesting that we're so clued in, at least in the pediatric emergency department, to clue into septic shock. And an important thing to remember is that sometimes sepsis can be only part of it, and that with the infection, the heart muscle itself can suffer. And so you may have a combination of septic shock and cardiogenic shock infection, so endocarditis or valve infection, toxicology, overdoses. That's can be rhythmic or can be respiratory, leading to cardiac. And if there's nothing to pump, the heart cannot generate cardiac output. In the previous talk, they talked about preload. So if a patient is super dehydrated, then it doesn't matter how great or efficient your heart is, you're going to be in hypovolemic shock, which the heart can't overcome that until you give preload. And then other types of shock: anaphylactic shock. We talked about shock a little bit already, dehydration if it's severe, and then bleeding. So those are all situations where there may be nothing to pump. Okay. So what are the warning signs? Wouldn't it be great if we had warning signs that if anybody has this, that, or the other, then we know they're at risk for sudden cardiac death, and so we're going to catch it really early. So palpitations, syncope, chest pain, and seizures. So the asterisk shows that 1/4 to 1/2 of the kids with sudden cardiac death may have had one of these symptoms. The problem is that these are the same symptoms that we see in healthy kids. And the most telling ones would be symptoms that are brought about by exertion. And then seizures can be a masquerade for long QT. The other caveat is that in pediatrics, this is a big difference from adult cardiology and adult medicine. In pediatrics, sometimes with long QT or hypertrophic cardiomyopathy or any of these diseases that cause sudden cardiac death is more likely to be their presenting symptom. So they went along, they may or may not have had symptoms, but never anything that came to medical attention. And these kids are more likely to present with cardiac arrest as their first symptom, way more than adults. So let's consider athletes, kids with congenital heart disease, kids with known arrhythmias, and cardiomyopathies. These are the groups that I would consider to have the greatest risk for sudden cardiac death. If we look at young athletes, just the demographics, they're more likely to be male compared to female. It can occur during or immediately after exercise. Barry Marin, who is a big guru at the Mayo Clinic with hypertrophic cardiomyopathy, has even published up to 30 minutes after exercise. Most frequently it occurs in the afternoon to early evening. Basketball and football account for 2/3 of the cases of sudden cardiac death in athletes. And then they think it's more common in formal practice or competition, but there may be a reporting bias. And then structural heart disease is another risk factor. There are guidelines, but I would say that there are more kids who have corrected heart disease who play sports. I actually have taken care of a 40-year-old with a single ventricle who was a hockey player. So, go figure. So sudden cardiac death with exercise. Non-traumatic deaths would include hypertrophic cardiomyopathy and coronary anomalies. If you add in myocarditis, then you have accounted for about 75% of all the cases of sudden cardiac death with exercise. Then traumatic causes would include commotio cordis, which is extremely rare, and cardiac contusion. Triggering events. So everyone has the ability to die suddenly if your potassium gets low, if you have extreme dehydration, etc. But if you look at triggering events, you still have to have some sort of structural substrate. In adults, it may be a scar or plaque in your coronary arteries. In kids, it may be a congenital arrhythmia, or it may be ion channel problem that causes long QT, or it may be a repaired heart disease with a scar in the heart. And then the other triggering event can be the autonomic function. Our heart rate is not a static thing. And so with exercise, the natural adrenaline is flowing, and that can be arrhythmogenic. Acidosis. So the heart doesn't like acidosis. Low potassium, increased adrenergic state, that's your endogenous catecholamines kicking in. And then hypovolemia is not well tolerated, especially in someone with a hypertrophic cardiomyopathy. Okay, so if we look at hypertrophic cardiomyopathy, I would say that it is probably the most common cause of sudden death under 35 years of age. It's an inherited or genetic condition, and there are all different types, different genes that can contribute to this, but it develops over time. So rarely will you have a baby that's born with a big, thick heart. And so it will usually present in older kids or at least tweens, and then often associated with exercise. So here is my first case. 15-year-old male collapses during a basketball game. The coach used the AED courtside, and when you arrive, the rhythm is normal sinus rhythm with kind of a wide-looking QRS complex and some ST depression, and what you would just say, like, these are bizarre T waves. They don't look normal. The kid has been previously healthy. He's a star player, and this is last day of a tournament. So he played all the games in the previous 2 days of the tournament. When you get to him, he's got kind of poor perfusion, cold and clammy extremities, looks maybe a little bit mottled. The pulses are palpable. There is a systolic murmur that is heard best at the left upper sternal border, and the blood pressure is in the normal range. And heart rate's about 100, oxygen saturations are good. So what is your differential diagnosis? I think in the interest of time, I'm going to power on through. So we've talked a lot about cardiomyopathy, especially hypertrophic cardiomyopathy. I will say that this combined with any arrhythmia is a really dreadful combination. Myocarditis, which is usually some sort of viral infection in the heart, or a dilated cardiomyopathy that's inherited. And then we don't talk about this too much, but this also develops over time. So is usually seen in older kids. It's called arrhythmogenic right ventricular dysplasia. It is a cardiomyopathy that primarily affects the right side of the heart and generates ventricular tachycardia. So obstructive lesions, if the mitral valve or the aortic valve are marginally narrowed or stenotic, then exercise is going to bring out that because you have to increase cardiac output with exercise, and a fixed obstruction is not going to allow that. So obstructive lesions could cause this, so undiagnosed aortic stenosis or something like that. Arrhythmias, long QT, ventricular tachycardia, primary ventricular fibrillation is what you call it when you can't figure out exactly what caused the arrest. And then Wolff Parkinson White can also be responsible for sudden cardiac death. Coronary artery anomalies, or then some weird fascinoma, such as a myocardial tumor, or anything else that's weird that the cardiologist will be scratching their head over. Okay, so these are kind of the biggies: coronary arteries, arrhythmias, cardiomyopathies, or obstruction. So this is what the scenario has sort of been built around to show what would happen with hypertrophic cardiomyopathy arrest. So if you talk about management in hypertrophic cardiomyopathy, should this kid get fluids? A big dilated cardiomyopathy and congestive heart failure in an adult with poor pump function, you do want to be careful not to volume overload them. But just like they were talking about with the LVAD, if this kid is clinically dehydrated, fluid is going to help him. So if he played for 2 days in the tournament and he sweats a lot, he may or may not have been keeping up with his fluids. The other thing is that in hypertrophic cardiomyopathy, the ventricle is big and thick and it's muscle bound, and it takes a decent amount of preload to actually fill the ventricle. And I'll show you some pictures from pathology reports of what these ventricles look like. Correct unstable arrhythmias. So this is a biggie. With this type of muscle-bound hypertrophic cardiomyopathy, they don't tolerate arrhythmias because a fast rhythm just means that there's even less filling time. And so if you can't fill the heart, you'd have nothing to pump. Usually, though, they have good function, and you may hear this super high-pitched murmur and think that this is a very tight stenosis, but it's usually dynamic. It's not like a fixed stenosis, and so even someone with a high gradient that gradient may not correlate with sudden cardiac death. If you look at these pathologic specimens, this is a normal heart on the right of the screen as you face it, and you can see the ventricular myocardium and then the sort of like triangular shaped right ventricle. You see the left ventricular outflow tract right here and the mitral inflow. If you look over here, there is this huge ventricle, and then you're starting to see these lighter places, which I think represent subendocardial ischemia. The mitral inflow is here. The aortic outflow is possibly not caught in this clip, in this section. And then the right ventricle even shows some signs of hypertrophy. So if you imagine the same two little coronary arteries supplying this muscle with oxygen and blood flow compared to this, you can understand why things can go south, when they get into a bad rhythm, etc. So these are cross sections. So this is cut where you see a cross section or the short axis of the left ventricle and the right ventricle. And you can just see that this is so severe, there's hardly any cavity. So you can imagine someone who's a little bit dehydrated really has really no way to fill this ventricle. Even in the best of circumstances, they need a low heart rate and low cardiac demand. So, you may get an EKG on some of these kids, especially in this situation where the kid has been resuscitated. This is just a look at normal. You can see there's nice narrow QRS. The T waves look like a little molehill. They're all pretty reasonable, and the rhythm looks great. So this is an example of a normal EKG. Now this is an adolescent with hypertrophic cardiomyopathy. And if you see these T waves, they're sagging. They should be upright. And the other thing to notice is these leads are recorded at the normal standard. So what you see is what you get. But this little stair step means that all of these V leads have been electronically recorded at half of what they normally are. So in your mind, you have to double the amplitude of each of these. And you can see if you had recorded it at the full standard, all of these QRS complexes would be overlapping. And so what you have here are abnormal negative T waves kind of throughout, maybe a little bit of strain, and then super high voltage. So the reasons, like they have all these different ways they can die with hypertrophic cardiomyopathy. And I think the fact that the mechanism for sudden cardiac death in hypertrophic cardiomyopathy involves several different ways make it one of the most common ways to, it puts hypertrophic cardiomyopathy in the top spot. So the thick muscle has the same coronary, so they're set up for ischemia. The cardiac muscle fibers are not uniform, so these are a setup for ventricular tachycardia. So instead of a uniform flow of electricity through the ventricular muscle, the electric signal can swirl around and cause reentrant ventricular tachycardia. And then the restrictive physiology means that the atrium is usually enlarged, and these arrhythmias can degenerate quickly. So that's what I have on hypertrophic cardiomyopathy, kind of a sample case. The next case is a 9-year-old female. And the mom found her possibly seizing just as her alarm went off. And she didn't have a known seizure disorder. Initially, she looked postictal. And then you get her in the truck and she's all hooked up to the monitors and she's actually chatting with you and checking out all the equipment. And then you see this. So this is a special rhythm that's called torsade de pointe, and it looks like a picket fence that's been picked up and twisted on the points. So it's a twisting of the points. And this is the characteristic rhythm or the type of ventricular fibrillation that you see with prolonged QT syndrome. So what do you do and what actually happened? I really like what Justin said in the previous talk about this. This is not you. You're fine. Just, check yourself and then do what you can do. So what do you do? So CPR, sure. You can do CPR, VFib, DFib, just as you would in the adult population. If you saw a ventricular fibrillation, the quickest way to correct it is to defibrillate. If you can, record the rhythm and then lights and sirens to the nearest hospital. So that's actually what happened. So the problem with long QT syndrome, well, I'll talk about why they degenerate into these rhythms. I think I have another slide coming up. The EKG is the way we make the diagnosis, and the clinical scenario is sudden syncope with exercise or stress, rapid recovery, or cardiac arrest. So if this rhythm spontaneously corrects itself, then these kids may just have episodes of syncope, which are sudden in onset. They don't have a lot of the prodrome that the vasovagal type syncope has, and they just drop dead, and then they wake up. And in my first job, I was at Los Angeles Children's, and I had a kid who was running at the there's like these grassy slopes out by the Rose Bowl, and the kid was running and just collapsed, and then said, "I'm okay, I'm fine," and went on about her day. But it always bothered the mom to the point where she brought her child in to be seen by me, the cardiologist at the time, and she had particular type of long QT that actually wasn't very obvious on the EKG. But if we look at this EKG, we measure the QT interval from the beginning of the little Q wave, and it goes all the way out until the T wave comes back to the baseline. And the baseline can be measured it can be established by this flat line between heartbeats, or if the heart rate is fast, you can use the PR interval, this little flat line there. And so whenever it crosses back to the baseline, that's where you mark the end of the QT. You can do a calculation. Most of the residents don't measure these by hand. They have like a little thing, but what it is it's the QT corrected for the heart rate, because we know as the heart rate increases, so say this kid starts running, the R to R interval, these two heartbeats are going to be closer. And so in response to a faster heart rate, the QT is supposed to respond appropriately by shortening. Sometimes with long QT, if it looks a little borderline, you put them on the treadmill, and when the heart rate comes up, the QT actually lengthens. That's bad. You can see here another demonstration of a prolonged prolonged QT interval in comparison to the normal. A poor man's QT correction or measurement will be if you take the halfway mark between two heartbeats. By the halfway mark, the T wave should be already at baseline and the ventricle should be repolarized. So that's kind of like a quick look that you might find helpful. If you know that the T wave extends way past the halfway mark between two heartbeats, that can be an indication of long QT. So I want to go back and I want to say that if we look at the simple EKG strip, the P wave represents the atrial electrical contraction. This is when that signal travels down to the ventricles. This is the ventricular depolarization. And from here to the end of the T wave, the ventricle is getting ready for the next beat. And I will tell you that this is the most unstable part of the cardiac cycle, because all the little ions are supposed to be getting back to where they're supposed to be inside the heart and get ready for the next beat. And so this is where this QT, if you prolong it, you've just taken the most vulnerable part of the cardiac cycle and you've increased that timing of vulnerability. So statistically, it makes it more likely to have VFib arrest with long QT. So, so that asymptomatic kid who has a sudden onset, sudden offset of syncope with exertion or exercise is the long QT sort of prototypical story. So case 3, I have an 8-year-old who was at field day back when they had field day and didn't have masks. And he complained of chest pain after the sack race and he vomited once. He was pale when EMS arrived, and you're unable to print the EKG, but you noted ST depression along the lateral V5, V6 leads. So this is a case that if you saw Q waves or ST depressions in an adult, you would immediately think of a cardiac arrest. And I've seen maybe 1, possibly 2 kids who have real coronary artery disease like adults, but usually they're born with some sort of abnormality of the coronary artery system. Generally, it's not acquired, it's congenital. They can present late with sudden death. They can present as babies, but often it's with exertion. And these are kids who have exertional syncope. Their myocardium typically is in good shape. So once they collapse, they may have improvement in the coronary flow. One of the anomalies that can occur, this is a normal heart. This is the right atrium and the right ventricle pumping to the pulmonary arteries. It'll come back to the left atrium, which is down here. The left ventricle is here. And so this is the right coronary artery arising from the right coronary cusp of the aorta. But if you look here at the pulmonary artery, this is the left coronary artery, and it's coming off of the pulmonary trunk. So this is what we refer to, like, it sounds super cool to say Al Kappa. It's the anomalous left coronary artery from the pulmonary artery, so Alcapa. It's pretty rare, and I think that the nausea with exertion is sort of a tip-off. Nausea in adults is a sign of cardiac arrest and myocardial infarction. We don't see it that much in kids, but in this kid, I think he had nausea because he had coronary ischemia due to a situation like this. Another thing that can occur, this is a look at the like a cross section across the aorta and the pulmonary artery. And there may be an anomaly where the left coronary comes off kind of between the two great arteries. And when exercise occurs and the blood pressure goes up, it gets squished. And that is a technical term. All right, so coronary anomalies will have EKGs, even if it's a baby, that will look like a STEMI. So if you see a STEMI in a small kid, then think of a coronary artery anomaly that they're born with. The case 4 is a 12-year-old with palpitations off and on for a year. They may have told people about it and nobody's really noticed it. Oh, you were running or you're hot, sit down for a few minutes. But this 12-year-old is running at soccer and she falls down and collapses. And when you arrive on the scene, you find the initial rhythm is ventricular fibrillation with spurious capitalization on this slide, says the grammar Nazi. So after successful defibrillation, what is your next step? So in this case, you want to get an EKG and record their rhythm and sinus rhythm. I think I have, I lost a slide, but I lost several slides here. So in Wolff Parkinson White, this is a case presentation for, they have an abnormal connection between the atrium and the ventricle. And sometimes with exercise, even young children, if they have electrolyte disturbances or a lot of endogenous catecholamines, may have atrial fibrillation. Well, the Wolff Parkinson White pathway will allow atrial fibrillation to transmit rapidly to the ventricle and cause ventricular fibrillation. So recording the post-resuscitation EKG is kind of the main point of this, and you may see Wolff Parkinson White. So then the question is, we have these sort of stunning examples of how kids can die suddenly that don't happen very often. But one of the things that we as physicians can do, and in the emergency department, we do primary prevention and screening. Now, sometimes this is pre-participation sports physicals. Universal EKG screening has been used in Italy for all athletes. There's some debate about the effectiveness. And then that it generates a lot more testing that is probably unnecessary because the EKG is not always the most sensitive test. Then primary prevention can occur in screening when we ask the questions of family history. Has anyone in your family ever fainted, died suddenly, had seizures that were completely uncontrolled by seizure medicine, which might indicate a cardiac problem? And then the other way we make a difference is with the chain of survival, early CPR by bystanders, public education, and then early defibrillation and access to AEDs where, people are not afraid to use them and know where to get them in schools and such. So EMS evaluation is extremely important. The first assessment is very valuable, especially the early EKG. It may normalize before the patient even arrives to the ED. And then EMS is important with increasing community awareness, teaching of pediatric CPR. Paramedics and firefighters are often ambassadors to schools. Kids really look up to you guys, and educating kids in CPR. There's actually some programs where you have to be able to be certified in CPR to graduate high school, and they've shown that kids as young as even 9 or 10 years of age can do CPR. One of my personal experiences with this is I have a couple of grandkids, and the 10-year-old is pretty good at doing dramatic death scenes where he will sort of clutch his chest and stagger and then fall to the ground. And at one point, his little 3-year-old brother, before he could really talk, runs over to him, rolls him over onto his back, and I'm not kidding you, locks his hands together and braces his elbows and starts pretending to pump on his chest. So I think that doing CPR can be taught to pretty young kids. So from an experience of one. I think that EMS also has a very important role with situational awareness at the scene. You know, you're pretty it's a pretty privileged situation where you might have some non-cardiac concerns if you're concerned for drug paraphernalia sitting on the table, or things that tip you off that the story didn't quite make sense. Concern for child abuse, and we're always happy to um, just sort of, I see the emergency department as sort of a continuation of what you've already done and collected the information and the kids, and that we can sort of follow up on those things. So let's talk about today and the future. With neonatal resuscitation, it's gone from the kiss of life to what we have now as neonatal resuscitation. We'll say a word about compression only CPR and its implications for pediatrics, which are not encouraging as they are in adult CPR. We'll talk about public access to resuscitation equipment, global collaboration, and education. So with neonatal resuscitation in 2020, the guidelines based on extensive evidence were sort of revised. And, if you look in the 1960s, there was neonatal resuscitation on about 20 per 1,000 live births, and currently it's only 4. And so the impact on neonatal mortality rate in the U.S. is largely due to the improvement in neonatal resuscitation. So approximately 1 in 10 neonates will need assistance in breathing, and approximately 1% of those will need further resuscitation. The key changes in the neonatal life support are umbilical cord management. Previously, there was a focus on clamping the cord and doing so expeditiously, but now the evidence points towards there is not a need for immediate cord clamping or resuscitation, and we can observe the infant and then clamp the cord in a more organized or easier fashion. Huge is temperature management. Skin to skin contact can be really important. There's concerns about skin to skin in the back of an ambulance, but I know that the home births and that we've received, there's always a huge effort made to keep these kids warm. Then IV or IO access, umbilical venous catheterization is the preferred. It's kind of difficult. We're lucky enough to have neonatologists on site who will come down, but IO access is also important, and that's an avenue that you can employ. So cessation of resuscitation, this is not a new question. Newborns after delivery who do not respond to 20 minutes of resuscitation have a very low likelihood of survival. And at this point, discussion should be initiated with the family and the care team. So this is more of an in-house recommendation. I think that if you are somewhere within the close to 20 minutes and you can get to the emergency department, continuing efforts until you arrive is reasonable. Okay, so chest compression only CPR. A lot of talk has been done about chest compression only in the adult world, it shows some promise, especially where people are unwilling to do mouth-to-mouth resuscitation in an adult. The only huge study that's been done in pediatrics was done in Japan. And so if you look at this, this is showing the incidence of survival with a reasonable neurologic outcome. And the black line represents any type of CPR whatsoever. And it starts in 2005 and goes to 2012. When chest compression only CPR was initiated, then the survival rate is not as great, but it parallels any type of CPR. And then conventional CPR with chest compression and ventilation shows lower results. So what this says is that any CPR is probably better than none, and chest compression only actually outstrips conventional CPR. So we have resuscitation sets placed in airports and in public places. This is an example of the resuscitation sets that were placed along the Thames River for the resuscitation of drowning victims. I don't even want to know what some of those little tubes are for. If we talk about strategies to enhance resuscitation training, which is probably the next level of in the chain of survival. So there are self-directed CPR training classes, training for community-based lay rescuers. Middle school and high school age children should be taught high quality CPR. There can be tailored CPR training to increase bystander CPR rates. We train parents whose children have had a cardiac event or have cardiac surgery. Strategies would be teamwork and in situ training, and high fidelity mannequins are also super helpful. And then other type of gaming sort of mechanisms to learn. I mean, with everything virtual, these methods are actually fairly successful and a lot cheaper. If we look at what the American Heart Association has been doing, they have been focusing on international life-saving programs. And in India, the American Heart Association focused on training CPR, and they trained 28,015 people to do CPR using low-tech mannequins, and they did this in 8 hours and 8 minutes. We talked about China and how they started out with the earliest reports of resuscitation, but they've really fallen behind with a very low chance of survival with out-of-hospital arrest. So in November of 2016, the Guinness Book of World Records recorded that China trained 50,000 people at one time to do CPR. And you can see them all laid out here in a stadium learning CPR. So there are a lot of things that we can say about sudden cardiac death and resuscitation. One is it has definitely come a long way. There are some ideas that started out that were dropped, that were picked up, and some that were just dropped mercifully. There is a low incidence of sudden cardiac death amongst the pediatric population. Many of these episodes are associated with exercise. Some have a known pre-existing condition, but some will have sudden cardiac death as their first symptom. It's emotional due to this being the unnatural history of what's supposed to happen in childhood. And we definitely need continued research. We need an emphasis on early CPR and educating the future, as well as improving transport and post-resuscitation care is probably where we'll end up saving more lives. So that's the end of my talk. I'm happy to answer any questions that you guys may have. Oops. I'm still here. Yes. Oh, let's see. I'm looking at the chat now. Can somebody help me manage the questions or?
I'm looking for some raised hands, if there's any new ones.
I'm looking.
Ted? Did you have a question from earlier?
I don't see any hands up. Oh, come on, guys. We like to badger our people with more questions than that. Come on.
I know I was in you guys' group last week, so I said to leave room for questions, and now everybody's super quiet. I feel like we had all this LVAD stuff. I was super excited to see the stuff for the hand, the not using the Lucas or the Zoll on people with LVADs.
Lauren Edmonds has a question.
Kind of tying the two together. Do they ever put LVADs in children?
They do. I was so interested to learn about LVADs. Yes, they do. And you saw how small they are. So size was one of the biggest barriers. We put in quite a few when I was working in Houston. I was actually working in cardiology as well as the ED at that time. And so the small size makes it very possible for kids who can accommodate the actual pump. And a lot of the things that we do to assess an LVAD coming in are exactly what they taught. I think that the biggest risks are stroke, infection. Sometimes these kids will have a lot of chest pain and you have to sort of sort it out. So infection, I have never had to cardiovert or defibrillate or do CPR on anyone who came in with one of these. But I will tell you that Laura, our EMS educator at Nationwide, is always very sure when we have a kid with an LVAD going home to sort of get a little cheat sheet together and notify the local EMS. This is the address. This is what they do, and it's sort of like a little teaser. Next week she's going to be talking about special needs kids, and so we do the same thing with any cardiac kid who has a severe congenital anomaly who's going home. We try to keep the local EMS informed.
Yeah, we just had somebody go home with a total artificial heart. So that was a co-managed with Ohio State. So I know some of the LVADs are older. A lot of times I get close to having some of the LVAD kids go home and then they get a transplant.
Which is good.
Yeah. So, but you still have some long-term complications. And I think, with Dr. Bubolz getting into the athletes and, all the cardiac anomalies and sudden cardiac arrest, is that we've gotten so good at repairing some of these pediatric things, even things like valve stenosis as an infant, that they may be teenagers playing sports. And so it may not be as readily apparent. But, oh, look, we got a question.
Yeah, we got a question. So the question is, if the trend is still that the majority of pediatric arrest is due to respiratory failure, or is that changing? I think that's still true. And I actually think, even though, 2012, hard to believe that's almost like 10 years ago, a decade. But I think that that's why kids don't do as well with compressions only CPR.
That is true. The vast majority of reports that we review, I don't know how many stations up in the Youngstown area, and I know there are several in the Cleveland area that participate in the CARES registry. And I think having some of that data, including the pediatric data for the next round of data that's going to be coming out, having that additional data, I think, is super useful. but it's mainly either respiratory. Unfortunately, this time of year with those respiratory arrests that would lead to cardiac arrest, you have things like unsafe sleep, especially as it gets colder.
Yeah.
What are you seeing in the ER from EMS that you think that we can improve collectively on? That would be my first question. My second question is, there's a lot of providers out here who get really hyped up when the cardiac arrest or the non-breather child comes in. What would you say to them, and how to kind of keep your calm and make sure you hit on those points? And finally, my third question would be, in the realm of COVID, how are you seeing these pediatric patients present? What are the treatments for these? And how many of the kids are in the ICUs that you're aware of? Because now the Omicron variant is spreading like wildfire throughout the emergency services, and schools are very prevalent to getting it now. So, can you share your experience on those questions?
Yeah, well, I mean, let's start with the COVID experience. So some kids can have a cardiomyopathy from COVID, and this is going to present with respiratory problems. They may sound like they have congested lungs. They may just feel really kind of run down, and it may be sort of an indolent presentation. There is a very low incidence of cardiomyopathy from the vaccine itself, but all of these kids seem to have recovered, and the vaccine has offered more protection than, it's in my mind as a cardiologist, a pediatrician, and that it's not a reason not to vaccinate even young kids. We were seeing COVID only in the older kids before, almost exclusively, and the younger kids before Omicron came over. The younger kids were relatively asymptomatic, and I can tell you that I worked last night, and just every single kid has COVID. We admitted probably 90% of the ones that we saw with COVID, and so I think in this situation you have to remember to keep yourself safe and wear your PPE. Don't tire of it. Take good care of yourself, because we need you out there. And then the other thing I would say is that, um, we haven't, I haven't had to intubate any of these kids. And so I'm sure that's just coming, but, I think COVID is just going to drain us, and just kind of try and keep your head up. Your very first question, can you remind me of what your very first question was? And then I'll address the sort of mental aspects of it.
Oh, you mean the CPR?
Yeah.
I
So
my
honestly,
original question was talking about, what are you seeing EMS bring into the hospital on any case, whether it's cardiac, and what tips could you give to us collectively as a group? Things you wish we could do better, things we're doing well, just from an emergency physician standpoint.
So I mean, I think that most of what you're going to get flack from is people in the emergency department who do not understand the constraints that you operate under. So I wouldn't take anything they say personally. They're probably just uninformed. And the other thing is, I think that from a cardiac standpoint, that first EKG, recording it and making sure that it is in the records, that somebody, it's like, here is the EKG. Do not lose this. This is really important, even if it looks normal, because that can be helpful. And so, I think that, and then situational awareness, I think just knowing, like, when you have a concern about the environment that the child was taken from, then, by all means, just share that. I think that the other question that you asked in the middle was, it's really emotional when you take care of a kid who's collapsed or a kid who's dead, and I think number one is debriefing, talking to somebody else who's been through a similar experience, someone who you trust, someone who you look up to. You know, sometimes we even have, if you have the bandwidth, which probably not right now, but if you have the bandwidth to stay around and debrief with us, that's when we have a death or we have a particularly difficult case. If we have the option to debrief, we always do. And I think that the warning signs to look out for are if you just keep going over something in your head and you can't resolve it, you can't get out of it. My brother-in-law years ago, like when I was a medical student, was a firefighter, and he said that once he got called to an arrest, and what he remembered was like, and this was like nothing that they tell you about. It was like the feel of the kid's lips, when he gave him mouth to mouth because he was the first one there and didn't have a mask and just wanted to try and resuscitate the kid. So it's going to be like the odd things like that catch you off guard, that can really sort of reverberate in your mind. And the best thing to do is I think, to talk to someone about it, etc. The questions that I see here are COVID kids presenting the same as adults. I don't take care of adults, but they're presenting a lot like the flu is probably the short answer. We're only admitting them based on symptoms or comorbidities. Our kids
I've gotten
having
a lot of follow-ups with the asthma exacerbations. So it's a child that might have, a previous history of respiratory issues, and then they get sick and they start having asthma worse than their regular asthma.
Mhm. Yeah, definitely. And then we have another question about are kids having hypotension issues that fluids aren't working on? So I think that if you're suspicious of something like septic shock, anaphylactic shock, etc., then giving fluids, you have to sort of fill the pump. They have this just dilated vascular system that needs to be filled. But with cardiogenic shock, so if the kid is on medications that suggest the left ventricle is not working, they're on carvedilol, they're on lisinopril, they're on all the adult medicines for heart failure, then you have to be a little bit concerned about giving too much fluids. And then pressors definitely are indicated. And I would say, probably the go-to is epinephrine. And especially if you do a code dose or a test dose and they respond to it, and then you can start them on an epi drip. But it sort of depends. If you know more about the patient, it can help. Your medical control can help. Definitely. So other questions.
See the one about the insulin pump.
I'm looking at that one.
And I was looking at that basically if you feel that somebody's pump is malfunctioning, I believe that's the meat of the question. Correct me if I'm wrong, Tom, but it would be acceptable to discontinue the pump if they had a glucose of like 4. I would just bring it with them.
Yeah.
You could put it in a bag and bring it with them to have that be evaluated and treat the hypoglycemia per whatever your department protocol is.
Yeah.
And then
Right.
I have one at the bottom with
Mhm.
cardiac arrest due to neglect. Unfortunately, abuse and neglect. I think that's one thing that I worked community ER before I came to children's, and that was one thing that they said the holidays can be notorious for. So abuse and neglect always could be a possibility for cardiac arrest. When you talk about debriefing and stations that can't stay for debriefing, typically one of their EMS captains or educators will, especially as we have a lot of stations that participate in the CARES registry, and they want to know when they put that data in, is there any cause? Because sometimes, EMS are met at the door with somebody just handing them an infant or toddler that's not breathing. And, when Dr. Bubolz had written earlier about the scene, if you're in the scene, if something doesn't seem right, if the story doesn't seem right, don't argue with them about the story. Just write caregiver states XYZ is what happened. And, treat the child, do a good assessment. And it's not that every single parent abuses or neglects their child, but that should be in the back of your head, especially if the story doesn't make sense, because it definitely happens out there. And
Yeah.
especially those arrest of those kids under 5.
I would say in babies, if you get a look underneath the tongue and look at the frenulum or the frenulum up underneath the front lip, if you see those are not intact. I've had one family brought in a child, almost newborn baby, because he looked like he was bleeding from his mouth. That's one of the sentinel injuries. Weird patterned bruising. So I've seen kids that were brought in after school and they had like electric cord marks all over their body. And so it's a patterned bruise. Other sentinel injuries would be bruising on the ear tips. A story that doesn't fit, like Laura said, or a delay in seeking care. That can be a little bit subjective depending on their resources, but those are the things. And I think we just have seen an uptick in I don't know about cardiac arrest due to neglect, but definitely child abuse in general due to neglect. It's I don't think it's as bad as when all the kids were staying home and couldn't go to school, but I think we are definitely seeing some stress in the families, and it comes out this way. And then the co-sleeping, we see that a fair amount, too often to yeah, that bothers me a lot too. So we see it a lot. So a lot, I would say, considering it's preventable. So any other questions?
Yeah, I have one question.
Yeah.
Hey, so Justin Coper with HealthNet, and I kind of have a differing perspective just from being in West Virginia. We have a little bit different requirement for sports physicals here in West Virginia, but related to sudden cardiac arrest in kids that are playing sports, kind of two-part question. One, do you see any benefits from routine like EKGs for kids that are going to be participating, especially in cardio-heavy sports? And is there any requirement that you know of for like coaches and other administrative staff with these sports teams to have any sort of education on the risk factors of sudden cardiac arrest? Because that might come into play a little bit when, we have EMS at the games, but they're spending 5 to 6 times as much time with the kids at practice doing the same exact activities, and they might not be able to recognize some of the risk factors.
Right. So I think that sadly, I will say that recognizing the risk factors in their star player is a little bit of a conflict of interest. And, you don't see it so much in the high school level, but at the collegiate level and higher, you've seen some cases where, like the kid in Boston where they just doctor shopped and they finally got Roger Mudge to sign off on this, blanking on his name. It'll come to me, but basketball player back in the 90s, and he had ventricular tachycardia on an exercise stress test, and the family searched around till they found a cardiologist who said he can play as long as there's a defibrillator at the courtside. And then he collapsed during a game or practice, and they were too embarrassed. They didn't want to shock pardon the pun. They didn't want to disturb the audience. So they sat there and they didn't do anything for a long time. And then he died, and they had a defibrillator sitting right there, but they didn't want to use it. So, this was the early days of AEDs. As far as universal screening with EKGs for sports, Italy does that with all of their elite athletes. Everyone gets a screening cardiac evaluation. I happen to be a cardiologist when the American Heart Association, unbeknownst to the American Academy of Pediatrics, went on Good Morning America, and they talked about Adderall being having a high incidence of cardiac death. And so at that point, there were practices that did things 2 different ways. Some practices took every single kid in their practice who was on Adderall and sent them to see the cardiologist. aka me. And so what I found in my personal experience is that I found 2 kids that had long QT. One had terrible ADD and was on Adderall, and literally she could not play sandlot ball with the neighbors without her ADD medication. But on it, she was a brilliant student and she got along with everyone. And so it was a real conundrum. I didn't really know what to do, but she clearly had a long QT. And this was picked up in a screening EKG. The father's side of the family and the father's medical history were completely unknown. And I think we see this a lot in our society today, having single parent families or you know, so I sort of adopted the idea that if you don't know both sides of the family history, that's sort of a big question mark. And so this kid would have flagged for not having adequate family history, and I would have gotten an EKG on her. What I ended up doing with her is I put her on Adderall and a beta blocker, and they seemed to cancel out the long QT, and she was still able to function and do well in school. The other kid that I picked up that was a long QT, when you asked about family history of sudden cardiac death, both parents were in the room and the dad was like, yeah, all the women on your side of the family pass out and faint. And so it turned out that there was a positive family history. So universal EKG screening could possibly pick up some of these, but maybe not more than a solid history and a high index of suspicion and a referral to their pediatrician when questions arise in the screening process. The downside of universal screening with an EKG is that the way we figured out the voltage criteria for left ventricular hypertrophy was we EKG'd hundreds of patients, and then we took the top 5% of voltage measurements and we chopped that off. So these 5% are in the top 5 percentile of LVH. So we're going to just chop them off, but they had normal ventricles. And these are going to be on the bottom 5%. And we're going to call between 5% and 95%, we're going to call that distribution normal. So by definition, 5% of the population is going to have left ventricular hypertrophy on an EKG without true left ventricular hypertrophy by echocardiogram or other imaging methods. And so in this respect, you're going to generate a lot of echocardiograms that really didn't need to be done. The other caveat with that is that most of the standards that we go by were from white males and white females. And so we do know from experience that in adolescent, African American teenage males will develop higher voltage and a normal left ventricle than white males. Not as much with females, but there is a tendency towards higher voltage with normal ventricles. So what you're getting for universal screening is you're getting some false positives that then have the added expense of echocardiogram, cardiac evaluation, you know, family stress, et cetera, et cetera. And so I think that going by the AHA guidelines, and they have a pretty extensive history, if that history taking is done properly, then I think you're going to pick up most of them. And then if you have a family history that is not available, someone is adopted, then you sort of have to, what we do is we just sort of wing it, I suppose. That may have a lower threshold for getting an EKG. I don't know if that answers your question.
Yeah, it does. And I'm actually really glad you mentioned the family history. And that's kind of part of the reason I asked, because here in West Virginia, we're dealing with a huge problem of, well, we call it down here grand families.
Yeah.
But we have about 19,000 kids across the state where the grandparent is the primary caregiver. And mainly because opiates have hit us so hard, it's because the primary parent is deceased as a result of an opiate-related overdose, and the grandparent's the only one left. So it's kind of a imperfect family history up to that point.
Right. Yeah, so that's a completely different demographic than we dealt with even back in the 80s and 90s. And so as such, you may even not know you may not know both sides of the family history if it's the maternal or paternal family raising the child. So that may have a lower threshold for an EKG. The good news is if one of the parents or both of the parents are in prison, that's perfect follow-up. So you can get an EKG on them. And, you know, that's easy access, but that's kind of like the only upside probably.
Yeah. Awesome. Thank you so much.
You're welcome.
Joe Mistovich, you have a question?
Presenting tonight, I have a question for you in regard to COVID patients. Obviously, the pediatric population is invasive in the pediatric population. One thing that EMS is seeing a lot in the adult population, also in regard to it's in regard to their SpO2 and oxygenation status, that we typically haven't seen is seeing adult patients that are actually showing up in the emergency EMS finally, they're sat in their low 70s, still awake, and they're in distress, but not the distress you would think they would be in. That's in their low 70s. Talking to a lot of the emergency medicine docs, are like, people walk in and we can't believe they actually walked into the emergency with low sats.
Yeah.
Now, are you finding the same thing with the kids?
We're not seeing that. It's not saying we might not, but I will tell you one of the other things that I was going to mention. Are you guys getting an echo or is that just me? It's just me. Okay, so one of the things we are seeing is the MISC. It's the multiple inflammatory systems in children. And this will occur a couple of weeks after a COVID infection. And the sad thing is that a lot of these kids can be relatively asymptomatic. Maybe they just had a couple of days of sniffles or a sore throat or something. And then they come in a couple weeks later. One of the criteria is to have a fever for 3 or 4 days. And then the rest of the criteria is all lab work. But that is one of the things that we're dealing with, and then that can have some cardiac implications. So they can have myocarditis, or and really it looks a lot like the COVID infection looks a lot like flu. The MISC looks a lot like Kawasaki disease, which is also a inflammatory illness. So yeah. So we're not seeing that treacherously low O2 sats coming in. And I think more particular to pediatrics, we're seeing a post-COVID multiple inflammatory syndrome. So there's a question about pre-workouts or energy drinks to an increase in pediatric sudden death cases. I think we're taking a small population and slicing it down smaller. Yeah, there have been some reports, but I think they're limited to case reports. And I think that I'm trying to think if I've seen any personally. I know I've read about them. So there was one, Laura, you may remember, some energy drink that was out some time ago, and people were drinking it with wine, and there was a lot of sudden cardiac death. I wouldn't say it's hugely a problem. I haven't seen it much personally, but I think that, when you start getting into the adolescent population, they're 16, 18 years of age, and they look like adults. Their hearts are the size of adults. They're having some adult type behaviors. Yeah, you could definitely see the same thing in pediatrics.
I feel like the dehydration seems
Mm.
to be causing the biggest issue. I mean, unfortunately, I think it might be hard to trace back if the pre-workout or whatever is making them more dehydrated.
Mm.
But, those are the kids, if they tend to have more issues, it seems to be that they're just overheated and dehydrated.
Yeah. Especially with hypertrophic cardiomyopathy. I mean, they're so dependent on their preload for cardiac output. I think we've just about made it. Any last minute questions?
I'm looking around for raised hands to see if there's anybody else that we didn't get a chance to answer.
I think maybe we got everybody. That was a really good discussion, everybody. I really appreciate when everybody gets into asking the questions. I think we learn a lot that way. And it's nice to network with people with a lot of different viewpoints. I think it helps quite a bit. Dr. Bubolz, I loved it. That was great. It was so informative. Laura, thank you so much. We appreciate that. Thanks for coming and volunteering your time. A lot of people don't realize that we've done this for $0.
That's
and we
awesome.
couldn't do that without people like you, without experts like you in your field. Sharing your talents and your knowledge with us is immeasurable. Thank you so much, you guys. We couldn't possibly do it without you. Everybody else, I appreciate your time again. Hopefully you're getting a lot out of this, this refresher class, and gonna take all this information back to your departments and back to your companies and spread it around. So thank you so much for giving us your time and giving us your talents. We appreciate that. And
it was all my pleasure. I really enjoyed it. Thanks.
Good. Well, this won't be the last time we do stuff like this, so we'll definitely keep you on the list.
Absolutely. I'll be ready to come back.
Dynamite. Thank you so much.
Thank you.
Thanks everybody for spending some time with us tonight, and we'll see you all on Thursday.
Thank you. Take care.
Everybody.
Bye-bye.
Bye-bye.